Got it. Yeah. Yeah. So everyone, welcome to Koncpt. Is my screen also showing the video of us? Is the screen only my? Is it showing me also, or?
Your screen is showing your screen and your face is there, sir.
Okay.
Your face should be there. It is perfect, sir. Now.
Okay, I just want to change. Anyway, so yeah, good morning. Will the student be able to speak? One more thing, just one last thing.
Okay.
Will the students be able to speak?
No, I will put them in a mute. Whenever they want, they can speak.
Oh, they can unmute and speak, right?
Yes.
Okay. Can anyone in the chat box say that is my voice audible for every one of you?
Yes, sir. Your voice is audible.
Oh, excellent. Thank you so much, Sibi. Okay. So yeah, today is going to be a 6-hour class. I need to finish the whole of community medicine. So welcome to Koncpt. Here I'm the SPM faculty. Just one word about me. I passed out my MBBS from Kerala. Then after which I finished my community medicine from CMC Vellore. After which I have worked in ICMR, and then I worked for an NGO, and I worked in, now I am present a faculty of a medical college, a private medical college, MS Ramaya Medical College in Bangalore. So I've been like in all fields experienced. So even the practical point of view is what we are going to learn. It's just not for your MRB. My classes, I always say before I start, I don't teach only for your MCQ exams. I teach you for your life. So whatever I've learned in my PG life, whatever I've learned as a clinician, post MBBS, everything will come into this, because SPM is a complete holistic subject. Okay, so when you come to SPM, the problem with SPM is there are two things. There are a lot of facts. Okay, now that is the biggest problem in SPM, and these facts make you go like this. Okay, and then there are concepts, and that's why we at Koncpt give you a lot of concept. Now this proportion is a bit low, but this proportion is a bit high, and that is why people, but there are some certain topics which people think are facts but can be taught in the form of concept, and that is my role. In 6 hours it is completely impossible any human being in this planet to teach the whole of community medicine, but I will be focusing on key areas where you will have to focus, where for the previous MRB exams, all these exams, they've been asking. So before I start, I want you to make this approach clear. My class will be based on certain aspects that before I start, I want you to make your note making, everything clear, just 5 minutes, because this is essential for every subject, not just for community medicine. Okay, so I'll give you a very simple example. This is not to waste your time, it's just to make you clear there are multiple methods. It's what your method that you prefer that you should choose. Okay, I don't I'm not very sure when the MRB date is. There's very limited time. So what you can do is, there are certain things which I can help you, but there are certain things which you need to know, right? So one way of things that I understood during the course of my, till my being a faculty of this thing, there are so many other things you can use to ease your way of learning. Now one way is, like, I'll give a very simple example. I finished my first year anatomy in what, 2008, and but till now I can't forget the course of the sciatic nerve. Any nerve, anything else in the anatomy, I don't forget. I don't remember, but the sciatic nerve I remember. Why? Because sciatic nerve I remember like this. First, I get up in the morning. Okay, I sit. Then when I get up, in front, I see a picture, that is GSF. Okay, just assuming on the bed, I get up, the first thing I see is the GSF. And then what I do is, I go to my room. In my room itself, I have the picture of my room. Okay, so in that room, there's a napkin. And then what I do is I go, okay, I go to the kitchen, and then I go, then I see that in the oven, I'm very hungry. I see a very juicy chicken, and there is a fridge, and in there is a plus sign. So then I thought, okay, fine, let's not use the chicken, I'll use ham. Okay. And but again, when I see the ham, I thought I was bigger vegetarian. So then I decided to make some popcorn. And with that popcorn, I go and watch the TV or sit on the computer. With this simple, I have an image in my brain that my whole house is there, and I'm put something which I don't know into my house. And that's how I remember the course of time. So when I get up, I'll get up with my on my L4 S3. If any one of you don't like this ink, I can change the color anytime. Just tell me when you want me to change the ink and all. Okay. So when I sit up, I'll sit on the L4 S3. And then the nerve goes to the greater sciatic foramen. Then what I saw the greater sciatic foramen, I go, I see a napkin which looks like the piriformis muscle. If you see the piriformis muscle in the atlas of anatomy, you'll see it looks like a napkin. Then I go. What is go? Go is going superior gemellus and inferior gemellus and the obturator internus. So the nerve passes through that, through these muscles, and then I go to the juicy chicken in the fridge. What is that? The juicy chicken. The chicken looks like a nice biceps femoris. Okay, and the biceps femoris, I don't like it. So then I go. I close the fridge. There's a plus sign. Okay, for the purpose of memory, I put that plus sign. What is that plus? It's the adductors. Okay, adductor magnus. But then I thought, okay, fine, I don't want add. And then I used ham. What are the ham? Ham are the hamstring muscles. Very simple. Okay, so adductor magnus and the hamstring muscle. So after I pass through this, I go to the popcorn. What is the popcorn? Popcorn is the popliteal fossa. Okay, popliteal fossa. After that, I go to the TV. TV, where the nerve end, tibial nerve, or the common peroneal nerve. That is the computer. So till now it's been like 2008. How was it, like 24 years? Oh my God, I'm getting old also. Fine, 24 years since I finished my anat, but fortunately or unfortunately, I didn't take anatomy, but still I can't forget the sciatic nerve course. Now, if you learn anatomy, the great thing is, if at all L4S3 an injury is there, everything will get affected. Or if the injury is at the popliteal fossa after making the popcorn, what will get affected? Can anyone tell me if the injury is at the popliteal fossa? Unmutant. Yeah. If the injury is at the popliteal fossa, where will the nerve damage be? What all nerves will get damaged? After I take the popcorn, I'll go to the TV and the computer, that the tibial nerve and the common peroneal nerve, right? Guys, are you getting me?
Common parallel.
Yes, excellent. Both the common peroneal nerve and the tibial nerve will get affected if the injury is above the popliteal fossa. So this is how, like, you have to memorize certain things, because certain things you cannot remember just by reading on the day before the exam. Okay. Now, note taking in my class should be based on this. It's based on the cornell notes. If you look at there on online, if you don't understand, the majority of what I'm going to take is going to be in this part. Okay. These notes should be in this part. You should divide your chapter like this. This part should be your keywords, comments, whatever you feel that, okay, sir is wrong in this topic, this is better, this fellow has told it better, this is where you think it's going. Fortunately, no. What I used to do during my PG preparations, I used to put my MCQs here. Okay, commonly asked MCQs. So whenever you write a note, as long as you are after your MRB also, you might be writing a NEET PG. That time also you might. So next, even if you are preparing for your MRB, you might go and write your NEET PG. These notes will help you. If you just write notes, you're not going to remember anything. Then the last lines, these lines should be the summary of what I've taught. So next, it's based on the times of revision. So the revision should not be reading the entire notes. The revision should be using the summary correlating with the MCQs. This is the only way you are going to crack any of your exams, any kind of MCQ. After 1 or 2 readings, this section is not required. Okay, you don't have to read this section at all. You are going to go to your summary, that will 5 to 7 lines, you pick it up, finish your MCQs. You think these are the MCQs that have been asked previously, finish it off, tuck, finish the topic, alas, your revision is over in minutes. Okay. Now, another thing I want is the facts. So I have something called the Quizlet app. Okay. I want all of you to just install that app called Quizlet. I'll just pass on the link at the end of the session. So what I'll do is, at the end of the session, all the facts that I'm going to tell, not all, some of the facts which I feel are high yielding and which you won't be able to answer, I want to keep on using the app. Just early morning, I'll give it to you by Monday. So early morning, just go through it, flip the card on both sides. Okay, it shouldn't be like, I know this answer, like when is World Health Day? It's just an example. When is World Health Day? That is April 7th. So when you see April 7th, there are two sides for a flashcard. Okay, one is the question and the other is the answer. So both ways you should be able to answer. That's the only way you are going to retain it. So when you say April 7th, you should be able to say, when is World Health Day? Okay, the same thing. When is World Health Day? You see, you should be able to answer April 7th. That's how you keep on remembering facts. Facts are, nobody is an Einstein here. Everyone is the same. Okay, it's how you understand how to use all these methods that give you an extra edge. Okay, so whenever you are using a flashcard, this is, if you're not using the Quizlet app or something, if you want to use plain paper, you want to do that kind of any kind of thing, like uh, kind of a way that you want to do based on papers, you don't want to use technology, go ahead, there's no problem. Okay, but don't make it as simple as what I have given you. It shouldn't be on based on like, it should have a, so the part in sociology and community medicine, that's what, from prehistoric era, humans never wrote anything. Okay, so that's the issue. So your brain has been always telling you to what? Remember, how were the cavemen writing to each other? It was all based on pictures. So whenever you see a flashcard, like, let's take the same thing, World Health Day. What is the theme for World Health Day? Health promotion for well-being, equity, and sustainable development. Okay, so you can put the something like plus SD. You'll think it's standard deviation, equity and sustainable development, and health promotion. So you can put something like a Harry Potter hat, if you have hands of Harry Potter. So it's wacky. You're not going to forget. Okay, HP. What is that? Health promotion for equity and sustainable development is the theme for World Health Day. That is on April 7th. Sounds funny. When you see that picture itself, you feel like, okay, fine. What does this picture like look like? It looks like the sorting hat in Harry Potter, or it's HP, or you can even draw an HP laptop. And okay, health promotion. Yeah, health promotion. So each time you repeat that flashcard, you're going to remember it better. Okay, this is just about, this is very essential because I wanted you to use this for anything, even for surgery of choice. If it's some wacky name, some person's name which you can't remember, you can use something, some picture to denote that name itself. Okay, yeah. So are you all, this is last, what is happening with community medicine is this: the moment community medicine topic is opened, yeah, anyone who's watched the movie will understand, but yeah, that's the problem. Okay, so let's begin our session. So with this, I start with a very interesting part of community medicine. That is your history of community medicine. Okay. These slides are similar to your notes. Whatever notes is there, it's the same thing. It's in a way, it's in a more colorful mode to help you to understand better. So let's go to history of public health. Is everybody on? Hello?
Yes, sir.
Yes,
Okay,
sir.
awesome, awesome, very good.
Yes, sir.
Fine. So yeah, so when we talk about community medicine, the first chapter that we open, it goes into the history of public health, and that itself will make you, oh my god, so I'm also sleeping. Okay, fine, leave. That's the issue. So when you talk about history of medicine, what I want to tell you is anything and everything that comes in discoveries of medicine, microbiology, pharmacology, it actually is part of the history of medicine. We are not saying that history of medicine is only for community medicine. Unfortunately, that chapter is only taught in community medicine, but it's a chapter for every subject actually. It's not like it's okay, this is just for community medicine. There are aspects of microbiology. There are history of medicine is a vast topic. It cannot be covered in 10 minutes. I'm going to cover it in 10 minutes because this is only for your exam point of view. So let's start with that. Indian medicine. Indian medicine started with Ayurveda. Everyone knows they have the Tridosha theory. Three, three, three. Okay, three doshas. That is Vata, Pitta, Kapha. That is the wind, gal, and the mucus. These were any form of if there was a disturbance in any of these three, there will be that will cause a disease, and that was the Tridosha theory of medicine. The first great Indian physician and teacher was called Atreya, 800 BC. Charaka Samhita, Charaka, he has found the treatment of hypertension using you can use a plant called the raw wolfia. Sushruta is the father of Indian surgery. That's also another MCQ. Sushruta Samhita is one book that he wrote during the 800 BC to 400 AD. Unani is a medicine surgeon. When you see, you feel that Unani is an Indian form of medicine. No, it has the origin in Greece. It was then passed on by the Muslims into India. Homeopathy, the name that you need to know, HH. Okay. Homeopathy, home to Hahnemann. Okay, HH of Germany. That was also what they do in homeopathy is what they feel is if you take small quantities of one drug and then give it to healthy persons, that itself will cause that will produce symptoms similar to those of the disease being treated. Okay, so basically, we are giving a suboptimal dose of drugs. Okay, which doesn't make sense to me, but a question of controversy. Yeah. Then coming to Greek medicine, Asclepius is the god of medicine. He had two daughters, that is Hygeia and Panacea. Hygeia is the god of health, that is prevention. Panacea is the goddess of medicine, cure. Apollo is the god of healing and diseases, son of Zeus and father of no, no need. Just remember Asclepius. You know the Asclepius god, that is the god of medicine. Okay. So Greek medicine had itself influenced in medicine in the form of prevention is also, see, Hygeia and Panacea are two daughters. So prevention is a very important essential role in the treatment of diseases. Now Greeks believe, now this was an MCQ, what are the four humors? Okay, sorry. What were the four humors? That is one MCQ. This is in Greek medicine. That is phlegm, yellow bile, blood, back bile. These were the flow of humors. It's an imbalance caused disease, similar to your Tridosha theory. Anybody who wants to tell who is this? Very simple. Hello. Most of you would have taken an oath in his name. He is Hippocrates. You won't have picture-based questions. I just want your knowledge. He is the father of medicine, Hippocrates. Okay. And we asked as one word because, but he is known as the first true epidemiologist. He wrote the book on air. His book treatise on diseases is called as Air, Water, and Place. He promoted that social medicine and hygiene plays a role in disease formation. Then other MCQs, Fracastorius is the founder, FF. Okay, Hahnemann, was for homeopathy. F is for founder of epidemiology, that is Fracastorius. Okay. Ambrose Pare can be asked in your surgery exam as part of it, is the father of surgery. Okay. So who's the father of public health? Anyone?
Cholera.
Excellent. Yeah. Cholera is known as the father of public health. I know it's a disease. It will be a confusion for all of you. Why? It started out in leave that. It was discovered, cholera was actually discovered by Robert Koch, which is also controversial. These are all Nobel Prize winning on them, but 1883. Incubation period is 12 hours to 5 days. So what is incubation period? I'm trying to bring in concepts of epidemiology with history of medicine. What is an incubation period? Anyone? Entry of organism to time interval between entry of organism to first clinical symptom. Okay. So the Vibrio cholera has passed on from one person and then entered another person. It will take an average of 12 hours for the clinical manifestation. What are the clinical manifestations? Watery diarrhea, excellent fever,
vomiting.
yes, excellent. If anything related to medicine, everyone will start answering. Okay, fine. But if I ask what is incubation period, nobody wants to answer. Okay, fine, no problem. So what is period of communicability? Anyone? It's simple. It's the word. See, most of community medicine is just, it's self-explanatory. Whatever the word is there, that word itself is the period during which the organism can pass on from the deceased, from the carrier or the deceased, to a healthy host or the deceased, right? Can incubation period be same as period of communicability to carrier or the deceased to the healthy individual organ? Okay, question. Can incubation period and period of communicability be the same? Anyone? No. Yeah. Either way, okay, it can be, because once the organism enters, some people can start being communicable to that disease. It need not be that immediately after it enters. It can sometimes even period of communicability can be even beyond the incubation period, right? For people who have been treated and then the disease has been resolved. Okay, what do you call that? You call that the convalescent period. Okay, I'm trying to introduce new terms. This is the only way I can teach in 6 hours. Okay, so the period of convalescence is the period when the person has been treated and his symptoms have resolved, but he can still be in the period of communicability. Can anyone give an example of that?
Cool.
Anyone who thinks that, okay, I have, my disease has gone, I don't show any symptoms. Okay, I'll give you an example. A person with jaundice, vomiting, then after 1 week it's resolved, but then again he's passing. Jaundice, vomiting, what kind of disease is that? Typhoid. Anyone heard of typhoid? Hello? Typhoid? Typhoid Mary, anyone has heard of? Hello? Okay, so, okay, anyway, leave that. Typhoid is a disease where even after the symptoms have resolved, person can be in a period of communicability. So what is anthropozoonosis? Can anyone tell me what is anthropozoonosis?
Victor.
Is it like this? Or is it like this? Vector borne. Somebody called vector borne. Anyone who wants to tell what is anthropozoonosis?
Disease spreading from animals to man to animals.
Okay, that's wrong. Okay, sorry.
Man.
Yeah, when it is, see, it should be this way. Whenever you say anthropozoonosis, the problem is your brain works in that direction. Anthropozoonosis from man to animal. This is where you can go wrong in your MCQs. This is where I need to correct you. So it's always, even if you say anthropozoonosis, it means that it comes in the Arabic style from back to forward. Okay. So always remember anthropozoonosis and all, you remember it in the Arabic style. So what is it? Anthropozoonosis infection is transmitted from animals to the man. Example is, classic example, rabies. Can anyone see that? Rabies. Okay, plague. Okay, plague. Then anthrax from your cows. Okay, don't forget this. These are the mistakes that you can make. That's why I'm focusing on those aspects. Zooanthroponosis. So this is where what one of you said. When you have to read in the Arabic style, zooanthroponosis. So man is coming later. So man to animals. Like example is human TB in cattle. Now there's a third aspect, amphicenosis. Amphicenosis means infection can be transmitted in either direction. Okay, it can be from man to animal, and sometimes the animal can pass it to man back. It's seen in diseases like Trypanosoma cruzi, Schistosoma japonica. Is it clear?
Yes, sir.
Yeah, excellent. Who is this? Who is this? Fast.
Jon Snow.
Jon Snow.
Jon.
Yes, excellent. He's Jon Snow. He's the father of modern epidemiology. So who's the father of public health? Yeah, the confusion will be always that father of public health is cholera. Father of modern epidemiology is Jon Snow. So he's the father of epidemiology also. If the question comes, it's Jon Snow. He studied the epidemiology of cholera in London from 1848 to 1854. That's a big, huge story. I cannot discuss in this class. So he followed an epidemiology pattern called the shoe leather epidemiology. That is by going house to house and do survey. That was known as the shoe leather epidemiology. And there is something called spot map. What is spot map? Every house he will go, he will mark. Okay, this house has infection, or this house has infection. This house doesn't have infection. So then he's getting a spot man. Okay. So remember questions? Shoe leather epidemiology, S. S for snow, shoe leather epidemiology, spot map. That's how we remember. Father of modern epidemiology. Anyone? Click. We are running out of time. This is Louis Pasteur. He followed the germ theory of disease. Okay, sorry for my slide. It's agent, man is the host, and then the disease. That's the germ theory of disease. Okay, what is the problem? If an agent is there, it should enter a man, it should enter a host, and then it should then cause the disease. Okay, Pasteur, another MCQ, coined the term vaccine. Okay, there's one more person coming who coined vaccination. Okay, don't forget that. Okay, I'll tell you how to remember that. Pasteur coined vaccine. Vaccines discovered by Pasteur are the car vaccines. That's how I remember. Chicken cholera, it's not cholera, it's chicken cholera. Okay, even if they put cholera vaccine as one of the options, just remember. Okay, go ahead. Okay, they have, even if it's written cholera, go ahead. What are the vaccines discovered? Cholera vaccine, anthrax vaccine, and the rabies vaccine. Okay. Anyone? Anyone with the answer? Wants to tell the answer? Type for okay. Some people are typing in the chat box. Okay. See, whoever wants to answer, I didn't check the chat box to know. Sorry. Excellent. Some people have answered really well. Okay, fine. Okay. Yeah. So who is this? Sorry. Wait. Yeah. Okay. So this is basically Robert Koch. Koch discovered, okay, Koch, you might have heard about Koch's postulate that the microbiologist will teach you. Robert Koch discovered the anthrax bacilli. Okay. Hello? He didn't, Pasteur discovered the vaccine, Koch discovered the bacilli. He discovered Mycobacterium tuberculosis and he discovered Vibrio cholera. Okay, leave that other aspect, Filippo Pacini, don't remember that. Okay, this I only take it for. Okay, he discovered three things. One is anthrax bacilli, tuberculosis, and cholera. I remember it as Koch remembers cat. Okay, cholera, anthrax, and tuberculosis. Car and cat. So what is the birth of primitive medicine? Anyone wants to tell who is this? Hello. Okay, somebody's typing. Anyone wants to tell who is that person? 1 second. Not this. This one. Anyone? Can be your MCQ. That's why I'm teaching this. Okay. This is
James
basic.
Lind.
Yes, excellent. James Lind. Okay. James Lind is basically giving people the sailors. The sailors. He's giving, what is it? Lime. Okay. Lemon. Okay. Why he's giving lemon? He thought giving lemon would. Actually, he did it the first one of the first trials. Okay. Now, it's in this trial, what he did was some sailors he gave lemon, some sailors he gave what? He gave some oil. Some sailors he gave like vegetables. It's not. I'm just. He put into 5 groups, and he saw that people who had lemon was prevented from this deadly disease. Scurvy you won't find nowadays, but at that time it was a deadly disease among her. Why can't I say it's a controlled trial? So I'm just bringing you the concept of RCT. Is it a controlled trial or is it not a controlled trial? In RCT, we always talk about randomization, but what is controlled? Can I say what Lind did was a controlled trial? What does the control in RCT mean? Anyone who wants to bring that concept? My God, I can't see your chats. Anyone who wants to tell what you mean the control? Quickly, because that's part of your epidemiology. I'm bringing all those concepts back. Okay, so in control, it means that what happens in an RCT? You are giving the intervention. You are deciding who gets what. So it is the person who person who experiments, who did the experiment, or who the researcher who gives that is controlling that trial. He will decide who will get this. But this was more of a experimental trial. This a trial which Lind did. He didn't choose who will get what. Okay, so he didn't have the control of what the intake of the food will be. It was dependent on the participant itself or the sailors itself. So whenever you observe the sailors who had who were given lemon, they were safe. Now what can I call it an RCT? This experiment, can I call it an RCT? Anyone? Yes or no? That's all I want to know. Can I call it an RCT? Yes, no, yes, no. Anyone? Is everyone like dozed off by now itself? Unmute and tell if you want. Yes, Swati to everyone. Yes. You can call James Lind's experiment as an RCT. I'm very disappointed. You cannot call it an RCT. Okay. No problem. Only if you say the wrong answer, I'll be able to tell you the concept clearly. So what happens in an RCT? Anyone? The full form of RCT is randomized control trial. So when I'm teaching RCT, I won't go into detail because I'm explaining here itself. Randomized control trial. Okay. So initially, everyone, what randomization means that everyone has an equal chance of entering the experimental group or the control group. Experimental group or control group. So that is your RCT, right? Everyone, if I want to go into an RCT of drugs used in MI, okay, there is drug A and drug B. Now, when I am going to participate in the study, I have an equal chance of either going into the arm that has drug A or going into the drug B, which might be the placebo or the standard treatment. But in James Lind's experiment, no participant had that equal probability. Okay, I can get a chance of getting lemon. The persons who chose oil will have oil only. They will not have the probability of going into an arm arm of people who are taking the lemon, right? Has everyone understood? I'll go detail a bit when we talk about in epidemiology, but have you understood what is the difference between James Lind's experiment and RCT? Yes, no, please, fast. Okay, fine. So James Lind was the first scientist to introduce the concept of preventive medicine. Anyone who wants to tell this? Who is this? Anyone? The person who coined the term vaccination. Okay.
Edward Jenner.
Yes, Edward Jenner. Okay. Fine. So Edward Jenner has, how do I remember who coined the term vaccination and vaccine? Edward Jenner has two N in it. So vaccination has two N in it. Vaccine doesn't have two N. Anyway, yeah, sorry. I mean this vaccine, sorry. This one, vaccine ends in one N, but there is one N here and it ends in N. So there are two N and Edward Jenner has two N. So smallpox was the first vaccine to be introduced into the preventive medicine world. It was found by Edward Jenner. Past other MCQs, Alfonso Laverin discovered malarial parasite in blood of infected patients. He was the one who found. Ronald Rose, he found that malaria was transmitted by Anopheles mosquito and described the life cycle of malaria parasite by that. He was another pioneer in he also got the Nobel Prize for finding that one of the mosquitoes that transmitted malaria was Anopheles. Walter Reed was yellow fever was transmitted by Aedes. Max Thieler discovered the yellow fever vaccine. Okay. Anyone? This is Ignace Semmelweis. Even if you don't know, it's okay. He's the father of infection control. If any of you are washing your hands, anyone who did not contract COVID due to hand washing, it's because of this person, Ignace Semmelweis. Okay. Anyway, question to this. Answer this question. Anyone wants to answer this question? Quickly. Quickly. Early menarche is the right answer. Okay. Now, when you think about this, do you think this is a question of OBG? It's a very simple question, but I made that question wrong. But actually, this question, when I came into PGOL, I realized it's actually a question of community medicine. Okay. Why? Because the first case control study was based on breast cancer. Okay. Okay. So what is it? It was Janet Lane Claiborne who used In 1926, what happened was it's very easy for you to know what is case control study from this person itself. Sorry. Okay. So case control, I'm just going into that. What happened was when Janet went to hospitals, she saw breast cancer patients. Okay. And then what did she do? She took history of all these breast cancer patients. And what she decided was, let me look at their relatives who were in the similar background, right? The relatives are all in the similar background, right? They come from the same locality and all that. But in the history, she asked a lot of menstrual history, age, anthropometry, everything, obesity, every single thing she has asked. And then she did something called very simple thing she did. She multiplied this, like crossed it. And then some found what? What is this called? Anyone? OR. I've written OR bar. Hello.
ratio.
Odds ratio. Exactly. So she has started from, she just did an interview. Okay. She started from the outcome. And her history was all these menstrual history, all that. And those were the risk factors. So when you go backwards, that is what happens in case control, right? Everyone's understood this?
Sir.
Okay, excellent. If you understood, very good. Now we go to something very simple. I want to take a simpler topic. Okay, so measurements of health. Okay. What is rate, ratio, and proportion? Anyone? Rate, ratio, proportion. So before you write your note, just write these two letters, numerator, denominator. This is where everything starts and ends. Okay, this chapter, any MCQ is based on what is numerator and what is denominator. Beyond that, there's nothing in the measurements of health. You can revise in 5 minutes if once you get this concept. Any uh, any indicator in community medicine is based on these two things. Okay. You just have to know what is your numerator and what is your denominator. Okay, 1 second. Yeah. So coming to the numerator rate. So in all these rate, ratio, and proportion, there will always be a numerator and denominator. It's just that there are some subtle differences. Okay. When the numerator is a part of the denominator and there is a follow period in that rate, then in that value, sorry, not rate, in that value, there is a time period involved, then you call it rate. Okay. Anyone can understand? Okay. So it's like if you're driving a vehicle, when you press the acceleration, you are going from 20 to 30. That's a velocity. That's the rate, right? The speed rate, right? Distance over time. That is your rate. So there's always time involved in rate. Okay. Always just remember speed. Just remember speed when you distance by time. So in the rate, there will be time involved. So what is infant mortality rate? Anyone? It's written on the board part. Can you just tell? What is the numerator?
Infant.
Infant death.
Okay. So what is infant? How old is an infant?
Till
Less
1
than
year,
1
sir.
year.
Anyone? Till 1 year. Excellent. So number of children who passed away, who died before attaining 1 year of age divided by the total number of live births into 1000 within 1 year. Okay, there will always be a time period involved in infant mortality. IMR for 2021, when you take that, it is the rate. There is a time period of 1 year in that. right? Everyone is getting it? Hello?
Yes, sir.
Yes, sir.
Excellent. Okay. Now, infant death, they are all born, right? So they would have born from the live birth, right? So numerator, will it be a part of denominator? Will numerator be a part of denominator is my question.
Yes.
Yes, excellent. At the end of this class, by the end of this class, I want you to be more confident. Even if you're saying the wrong answer, just say it with full confidence. I don't care. Okay. No, I've seen this trend in South Indians especially. Yeah, we know the answer, but we tend to just keep quiet. Or all of you are sleeping. If you're sleeping, then I'll stop the class. I have no problem stopping the class. Hello? I'm pretty serious, okay? Anyway, hopefully you're not sleeping, I'm hoping. That's why I don't like, I personally, I don't like online classes. Okay, I want to see you, I want to see your face. I'm not able to understand if you are understanding also. But yeah, unfortunately, these circumstances are like that. Anyway, so ratio. When you come to ratio, what is it? What is the difference between rate and ratio? In ratio, the numerator need not be a part of the denominator. In my class, I gave a ratio till now. Can any one of you tell what is that ratio? No? Hello, one second. One second. No? Yeah. Yeah. Anyone can hear? Can anyone speak?
Yes, sir. I'm hearing.
Sir.
Okay, I can't hear you. One second. One second. No? Yeah. Anyway, yeah. Can you just talk again? Sorry, I lost my audio. Hello?
Yes, sir.
Yeah.
Yes,
Yes,
sir.
sir.
Okay, excellent. So in my class, I've told one ratio. What is the ratio in my class? I want to
Odds
see.
ratio.
Excellent. So what is happening in odds ratio? What do you do in odds ratio? Cases are there, control are there. Okay. And something like minarchy is your exposure. Okay. And early monarchy and late monarchy. These are your exposure factors. Okay. And you have A, B, C, D. And what happens in odds ratio? What is odds ratio actually? The odds of disease among exposed divided by odds of
Non-exposed.
disease among non-exposed. Okay. Is these two groups part of each other? Is the numerator part of denominator?
No.
Yes, excellent. That is the concept in a ratio. You have the exposed group and you have the non-exposed group, and you are finding the odds between them. That is your ratio. Other examples are maternal mortality ratio. Why is this a ratio? Can anyone tell? What is the numerator? It's there on the board. Numerator is your maternal deaths. Okay. And you have your live births. So the children being born has no relation with this. Okay, the maternal birth. Right? Are you getting my concept?
Yes, sir.
Excellent. So what is maternal mortality rate? I told you ratio. Now what is rate then? Numerator will be part of?
Denominator.
Denominator.
Excellent. So what will be the denominator in maternal mortality rate?
Reproductive age.
Excellent. Are you getting the concept now? Excellent. Whoever's answered it's really brilliant. This is not a ratio because why? The numerator is part of your denominator. So it changes everything. So you get a rate, okay, over a period of time. Next is your, can anyone tell me what is the number of females for every 1,000 males? Anyone?
980.
Sex ratio.
Excellent. Who told us sex ratio,
Sex.
female sex ratio? Okay, can someone tell the answer to this? Question mark. Can anyone tell the answer? What is the female sex ratio?
Oh,
What is the definition of female sex ratio? That's why I put this question. The number of females per 1,000 males. So in this, how many males? There are 10,000. So for every, and it's in the 1:1 ratio. So if there are 1,000 males, there will be 1,000 females. So the answer will be
5,000.
no. The
One.
answer will be none of the above. Because why? You want per 1,000 males, right? Per 1,000 males. So how much is the per 1,000 males? It is 1,000 females. So there's no 1,000 in your answer. Okay.
Yes.
Okay. Odds ratio I have already told. So what is proportion? Rate ratio and proportion. We're coming to the last part of this measurement of health. Proportion, what is the difference? What is the difference between proportion and ratio?
No time duration.
Yes, that is rate. Okay.
Numerator and denominator. Numerator.
Numerator is part of the denominator. It's like if you go and order a pizza, today itself you go and order if you want. Right? You go to Domino's and you buy or order pizza and you took one slice. Okay. What has happened? This slice came from this pizza? Yes or no? Or it came from the moon? Huh? Can anyone tell me? Where did the slice come? It came from this
From the
pizza.
tree.
Okay, so then the slice is part of that. The slice is like your numerator. Okay. It is part of the denominator.
Denominator.
Okay, very good. Okay, so the denominator is your whole pizza. Same concept is in proportion. Okay, there's no problem. You all are very attentive. I am very happy with the way you have been answering. It's very nice. So, yeah. But the problem in proportion compared to rate is there is no time duration. It won't be like within 1 year, within 2 years, it is like snapshot. You want it at one point of time. And in this multiplier will be usually into 100. So it will be expressed as a percentage. Okay. So 60, if I say 60% of elderly had falls in Chennai, is that a rate ratio proportion?
Proportion.
Excellent, very good. So incidence and prevalence. Can you tell me what is proportion, what is rate, what is ratio? Is incidence a rate? Is incidence a proportion? Is incidence a ratio?
Ratio.
No. Anyone else?
Proportion.
No.
Oh.
Then there's only rate left.
Rate. Rate.
Okay, because that is the last thing that is left. Anyway, fine. So that means I think you understood rate ratio proportion, but you don't understand what is incidence. Okay. So what happens in the incidence is you have one time period. This is, let's take 1st December 2022. And this is 1st December 2023. So when new cases come up, okay, in this period, and the old cases are not looked into. Okay. It is called incidence. And it is the number of new cases that arise within this time period. So is time involved?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So it's a rate. Okay. Is numerator a part of denominator? It is this population which at risk that we are is the denominator.
Yes.
Okay. And the new diseases. Okay. That is the denominator. Okay. So it will become. So now let's talk about prevalence. What is the prevalence of falls among elderly in Chennai? It is 60%. So is it rate, ratio, or proportion?
Proportion.
Excellent. Very good. Very good. So now you got an understanding. So prevalence is P for P. If you forget for your exam also, just don't forget this. P for P, prevalence and proportion. So what happens in prevalence is when I want to know the prevalence of falls in Chennai on 1st December, I'm checking how much is the falls. There is no time involved. Okay, so you are looking like a snapshot, one period of time and seeing what is your proportion of diseases, and hence prevalence is a proportion. Okay, let's go to mortality indicators very quickly. We have a lot to cover. Life expectancy, it's a positive mortality indicator. True death rate, it's a rate. So number of deaths in mid-year population, it's the simplest indicator of mortality. Okay. Crude birth rate, what is it? It is the number of births in the mid-year population. Growth rate, what is the growth rate? It's very simple. Crude birth rate minus crude death rate is your growth rate. Then specific death rate. There are, what is specific death rate is, what is the age specific death rate is? 5-year death rate. Okay, 5-year death age specific death rate is equal to deaths among 5 years. Okay, divided by the mid-year population among 5 years. Okay, it's basically your death rate only, just that your numerator has changed and the denominator will change depending on that numerator. So if your age is death among 5 years, you shouldn't take the entire population, mid-year population. You should only take the mid-year population of that 5 years. If you're taking above 60 age specific death rate, it means death among 60 years divided by the mid-year population among all the 60 years. Next, we go to disease specific death rate. Disease specific, like if I take what is TB specific death rate. Okay. TB specific death rate is basically your anyone who has deaths due to TB. Okay. Now TB can affect all people, everyone in the population. So denominator will be mid-year population of the whole population you are considering. Okay. Got my point?
Yes, sir.
Okay, numerator will be part of the denominator and it's over a period of time. Proportional mortality rate. This is for understanding the burden of the disease. Okay, how you will know the burden of the diseases? You want to know TB proportion mortality rate due to TB. Okay, what that means is you want to know deaths due to TB and then deaths due to all cause. What is this good for? If you are a public health person, you want to see a community and you want to see why people are dying. And if people are dying, 80% of the people are dying due to MI. Okay, the proportional mortality rate of MI is 80%. 80% of your population or not population of the deaths any kind of death is due to MI. Rest are 20% is due to TB, leprosy, all those AIDS. So if I am a public health person, I want to reduce the deaths in that population. I would try to attack this disease. That is MI. Okay, got it? What is case fatality rate? Anyone wants to answer? Hello? Number of deaths due to a disease.
By the number of persons who was
Okay, number divided by number of persons with the disease. Okay. My God. So will that be a rate or a, but this is not over a period of time. It is just at that moment that I'm trying to find the case fatality rate. So is it a rate or a proportion?
rate.
No. Okay, I told you it's not over a period of time. It's at that particular moment, more how many people with this disease had deaths. Okay, so it will be a proportion. Okay, it cannot be a ratio because numerator is part of the denominator, and it shows the killing power of disease. Why do I say it shows the killing power of the diseases? When there are 100 TB people, I say that 80 people died. So what does that mean? Whoever gets that organism, almost 80% of the people are dying. So that is almost like telling you how 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 crazy that bacilli or viruses. I'm just going and kill, enter, kill, enter, kill, enter, kill. So it's a killing power of the disease. You can understand only from the case fatality rate. It also tells about the virulence of the organ. Virulence means what? The how much active or how much like uh, how much crazy it is. Whatever you want to think like that, you can also think like that. Yeah. So simple. 100 cases of yellow fever, 80 died. What is the case survival rate? Can anyone answer this? Hello.
20%.
Excellent. 20% is your case survival rate. Is it a rate, ratio, or proportion?
Proportion.
Excellent. We are not following over a period of time. That is your concept for this. Can I take a break for some time
Yes.
before we go to
Yes,
the
sir.
next? Okay, sure. Thank you.
Yes, sir.
Just
Yep.
just 5 minutes, huh?
Okay, sir.
6:15.
6:15 will start.
Sir, can't hear.
Yeah. Sorry, I'm
Ah,
unmuted.
yes, sir.
Okay, fine,
Yes, sir.
So
Oh,
yeah,
fine, sir.
yeah, fine. So when we talk about disease, the first thing, every disease has a history to itself, and that is the natural history of the disease. How does some microorganism get into? I just need to take this call. 1 second. Hello. Class bye. Concept class online. Bye. Yeah. So yeah, that's what. Coming to natural history of the disease, every disease has a own history of itself, and that is how a agent comes inside a host and then develops a disease. And that is your. Can anyone tell what is that? Agent host disease. Oh my God.
Epidemiological triad.
No, that is without the disease. Louis Pasteur told agent host.
Germ theory.
Germ theory.
Germ theory
Yes,
of disease.
excellent. Germ theory of disease. So you should understand that how a disease developed, there has been many theories. Like I've told you, there's the Tridosha theory, there's the four humors, and then there's the germ theory. Before the germ theory, there used to be spontaneous generation. There used to be something called the miasma theory. So after Pasteur came only, we understood, okay, there must be some agent and that has to enter the human organism and that will develop a disease. But there is one more concept in the agent host interaction, and that is another vital important thing in the natural history of disease, and that is your environmental factors, and that is what you call the epidemiological triad. Okay, now you understood agent host disease. Okay, when your environment comes into it, then only a disease starts happening. So that is actually your pre-pathogenesis phase. Always remember the symptoms have not started. It does not mean the moment the symptom has started or the agent has entered the human being and start the pathological process, That is called as the period of pathogenesis. Then only you will understand. If you know this distinction, then it will be very easy to understand the difference between levels of prevention. Okay. Agent is there. Okay, let's take an example and tell you. Agent is there, TB bacilli. Host is what? Humans. The environment is the surroundings. TB is interacting with you, me, when you go to the hospital, when you go to the ward, TB is around you, right? Some patients will cough and they have cough, TB bacilli, and they are roaming around in the environment. But it has not entered your body and it has not started forming the Gons focus. It hasn't started causing a disease process. This is your place of interaction that I want. This part is where I want you to understand the prevention of cure. The cure starts, the treatment starts, the diagnosis starts. This is the point where after you enter, the disease process happens. That is where your early diagnosis and the treatment starts. Now TB has entered in you and it is roaming around in your lung. Then it has caused a cavitation. You are debilitated. Now what has happened? The complications has arisen, right? Cavity is an complication of TB. Or you had a pneumothorax. Some pneumothorax has a complication of a TB infection. This plane, each section I'm telling you so that you understand where the prevention starts. This section is where your secondary prevention and tertiary prevention is taka. Okay, preventive. So tertiary prevention is for prevention of you have TB, you've been diagnosed with TB, but tertiary prevention is prevention of disability. You don't want to end up with a cavity. You have the disease, but you don't want to end up with a pneumothorax. That is where you want to limit the disability caused by the disease. If at all you've been developed a cavity, you want to rehabilitate yourself. That is what is tertiary prevention. So I think you got the distinction between primary prevention and secondary prevention and tertiary prevention. Now, so what is primary prevention? So primary prevention is when you are walking in the ward. How are you walking in the ward? Now is the period of COVID. So what are you walking with?
Wearing mask.
Excellent. You are wearing masks. It doesn't mean that TB bacilli has entered your body, right? It's roaming around in the environment. Agent is the TB bacilli. You are roaming around and you are using specific protection, right? And when you are educating others, okay, you are educating, okay, you should follow good practices. You should wear mask when you are going to you should keep hand washing and all those kind of things. Any kind of respiratory illness, you are doing a health education, and that education parts become part of health promotion. Okay. If you know all this, then any kind of prevention is simple. Now, let's go to one more level of prevention where you will not understand is the primordial prevention. Okay, so now you have a disease. Let's take a non-communicable disease, diabetes. Okay. Now, in diabetes, obesity is a risk factor, right? Everyone knows that obesity is a risk factor. So you haven't developed diabetes, but you have obesity and you want to prevent obesity. Okay. That will be a primary prevention. The disease has not developed, but you are telling lifestyle modification, reduce calorie intake, and exercise, all that will prevent you from developing diabetes, and the risk factor is obesity. Now, when you want to remove that risk factor itself, Okay. When you not the risk factor, you want to remove the development of the risk factor. Like even before obesity.
Thank
What is that? In childhood itself, you are adopting healthy lifestyle and all that. That part will become part of primordial prevention. Okay, if you understand primary prevention, then it's kind of easy to remember primordial prevention. When there is weight reduction, when there is lifestyle modification, you want to prevent diabetes, then it becomes primary prevention. But when you want to prevent the risk factor for diabetes to arise, what is the risk factor? Obesity. You want to prevent that risk factor, which will lead to the disease itself, that is called as primordial prevention. Okay, adopting healthy lifestyles even during childhood is an example of primordial prevention. Primary prevention, easy, prevent the risk factor to develop into a disease. There are two parts, one is health promotion and the other one is specific protection. I have explained health education is part of health promotion, lifestyle modification, food fortification. Okay, example of food fortifications where you try to increase, like there is salt, you want to add iodine into it, so then people have iodine consumption in, even if they are taking salt, they don't need to take iodine as such. This like iodine, the rich iodine will be seen in fish and all. If people don't take fish, even if they take the salt, so there you are promoting health, right? Not specific protection. In specific protection, you are giving specific instruments to prevent that disease, like your mask, that is personal protection, bed nets for malaria, condoms, vaccination, nutritional supplementation, all that will be part of your specific protection arm of the primary prevention. Okay. Then coming to secondary prevention. So secondary prevention, the disease has entered. Okay. So you have to start diagnosing it and giving treatment. Okay. So screening, S for S. You start a health camp. You after you passed, you got excellent results on your MRB. You joined the health service. You found that you have to have a health camp for cataract. Okay. So now you start screening for cataract. You call the ophthalmologist and then you say that we want to do a screening camp, and that screening camp is on cataract. Okay. So what is that? Is that primary prevention or secondary prevention or tertiary prevention? Anyone? Answer.
Secondary.
Excellent, excellent. It's secondary prevention because the cataract. But if you go for a health camp and then you start talking about cataract, you are trying to educate the elderly about cataract. You don't know if cataract has been happened in the patient, but you're saying cataract is one of the leading cause of blindness in people. It causes refractive error. It causes there is increased risk of chance of falls. When you do that, what is it happening? What level of prevention is it?
Primary.
Primary.
Primary prevention, part of health promotion. Okay. Getting my point?
Yes, sir.
Excellent.
Yes, sir.
So after secondary prevention, your next this thing is tertiary prevention. So a person you screened. Okay, wait. One common MCQ is cancer registry. Okay. You have a registry of all the people who have cancer in Tamil Nadu. Okay. What level of prevention is this? This is a recent question. That's it. Can anyone answer?
Tertiary.
Again,
tertiary.
Tertiary.
No, it is secondary.
it is secondary.
Okay, in your park textbook, it comes under your secondary prevention. But I would agree with the people who are with tertiary prevention because you have something called a hospital-based cancer registry, where you will get patients from stage 2, stage 3. I don't agree with the concept that it is in secondary prevention. It can be in both secondary and tertiary, but it can be part of it. More inclines to the answer to secondary prevention, and also it comes in park as secondary prevention. But when you have a registry of patients with stage 2, you can prevent them from going into stage 4. So what is that? You don't
Second.
want that
Tertiary.
becomes tertiary. Excellent. Then you're getting the concept. Excellent. So if the question is there, you should go to secondary prevention. But to understand what is tertiary prevention, I just put this question. If a complication has happened, you want to limit that complication. A diabetic you have diagnosed, a person has developed diabetic nephropathy. Now you don't want the nephropathy to aggravate. What is that called? What level of prevention?
Tertiary.
Tertiary prevention. Excellent. Tertiary prevention. And there you are trying to limit the disability, and then you are trying to rehabilitate the person. You're trying to give him erythropoietin. Trying to give him, you are trying to support the body to survive. So the last stage of life. Now, a very simple thing is commonly asked: disability limitation. It is involved. There are three things. That is IHD. Always remember in this order, IHD. Why? Because that's where you make the mistake. Impairment, you start. What is impairment? You lose some anatomical structure or function. Okay. Can be your foot also. Then you have the disability. What is that disability? Because you lost your foot, what? You can't walk. Okay. No, sorry. Yeah, IDH. Not IHD, sorry, it's IDH. Okay. Not IHD, it's IDH. And H is your handicap. So what happens? Because he cannot walk, he cannot go to his work. That will become handicap. Simple. Anyone who wants to answer? A. Accident will be
Injury.
Injury.
excellent. Very good. Loss of foot?
Impairment.
Excellent. Cannot walk?
Handicap.
Disability.
Disability.
IDH. Okay, IDH. Unemployed?
Handicap.
Handicap. Because the problem is your brain will always go handicap. Okay, if you don't have a leg, it's handicap. No. In our preventive medicine, we say handicap means person cannot go to work itself. Okay. Understood till now? Is my
Sir.
class okay?
Yes,
Are
sir.
you able to
Yes, sir.
understand all these concepts?
Yes, sir.
Okay. Next, we are going into, yeah, we'll have to go to something regarding health and disease. Okay. Yeah, some bit of writing. These are short classes, okay? It's very, you have to read your books whenever you have time. I can't cover the whole thing, okay? This chapter. Yeah, health and disease. So, what is the first thing? Like, health is like something positive. When you feel that you are okay, you want to feel, I'm fine. But we as public health physicians, or we want to look at the population, right? Even if you say, if any one of you say, I'm healthy, I don't, as a public health person, I want to know the whole, like the whole Chennai. Is Chennai healthy? Or is Chennai suffering from diseases? I want to know that. That is what you get from indicators. This is why you are having all these problems with all these indicators. Why do you need it is the question. The question why you need it is only if you do that, only I can measure. Right. Okay, you told you are healthy. Another person told you is healthy. Another person, he said, I am having some cold. Some person said, I'm having vomiting. What can I tell about Chennai? Can I talk about Chennai? Is Chennai healthy? Hello? Can I? No.
No, sir.
Excellent. Next. That is why we use certain indexes. And one of the indexes that you need to know is PQLI, and the other one is HDI. Okay. Easy way to remember. I told you now, impairment, disability,
Disability and
handicap. So if you put it opposite, you'll get HDI. HDI is nothing but the Human Development Index. Okay. PQLI is the Physical Quality of Life Index. Okay. Okay. tricky because you might be thinking, oh my God, how will I remember what is an HDI? What is in PQLI? Simple way of remembering this. HDI. Okay. So you should remember this H as B and I. Okay. Why I'll tell you. There is one more thing why I'm telling. Because always the MCQ will be life expectancy at age 1, or is it life expectancy at birth? Can anyone tell what is in HDI?
At birth.
Anyone else? Anyone else? What is HDI? Anyone else? Okay, very good. And that's what I'm put HBI. Okay, BI is for birth. Okay, this is where the confusion happens. Is it life expectancy at birth, or just remember the D as B, PQLI. So when you look at LI, you should remember life expectancy at age 1. Okay. Always look at that last I at as 1. This is the difference. Now, the second difference in HDI and physical quality, there's a lot of physical activity, but there is no money involved. Okay, so money is always in HDI. It is like hi-fi. You are like highly developed. That is what you have income involved in HDI. But the physical quality is like you want physical parameters, the beauty of the environment, not environment. You want the people's. Even if you have money, it doesn't mean that you will be physically fit, right? So money is not there in PQLI. Remember that. Okay. Next, literacy will be there in both. Okay, money is there in HDI, literacy is there in HDI, and next is life expectancy at birth. So HDI, you got all three, and money is said in income. Okay, it can be in per GNI per capita in US purchasing power parity. Leave that. So you got HDI. In PQLI, you got L1, life expectancy at age 1. There is no income. Again and again, I'm stressing no income because that will be the fourth option. PQLI involves all of the following except. Then literacy. Literacy is there in both. Now, instead of money, we want to look at something called infant mortality rate. How many? I told you, right? 1. PQLI has 1 in it. And that 1 is 1 year. So life expectancy at age 1, and infants are up to
Age 1.
age 1. That is why 1 is important in PQLI. Infant mortality rate and both. Okay. Now, after that, yeah. How do you define BPL? That I want to. BPL. What is BPL? Below poverty line.
Below
So,
poverty.
one way of looking at below poverty line is talking about how many people are having how many calories. Okay. Another way is looking at the income. There are two ways of looking at below poverty line. One is calorie intake. In rural, we are thinking that if in rural, do we need more energy or less energy compared to urban?
More energy.
More energy. Okay, so less than 2400 kilocalorie per day if they are getting in food, then they are known as BPL. In urban, if that is less than 2100 kilocalorie per day, it is known as BPL. Again, below poverty line. Income. Income wise also you can find this is based again on the rural and urban. Again, use your brain. Do you need more money in urban or do you need more money in rural?
Urban area.
Urban area. or
Urban
rural
area.
Okay, excellent. If somebody has less than 33 rupees in urban area or less than 27 rupees in rural area, then they are called BPL. Okay. Now the that is according to, there are two committees. There is one is Tendulkar committee and the other is the Rangarajan committee. If they are asking according to, they will ask if they're asking BPL, if there is income, I would prefer the Tendulkar committee. If you can remember only this, fine. But rupees 27 and rupees 33, anyone who can. Now Rangarajan has reframed it saying that less than 32 you should count as below poverty line and it should be less than 47. You need at least 47 rupees in the urban community. Then only you can say it is BPL. So there are two ways. One is calorie wise, you can check, and the other is using income wise. Okay. Then what I want you to know. Yeah. Yeah. Another thing I want you to know is DALI and CALI. So what is DALI? It is disability adjusted life years. Hello.
Yes, sir.
Yes, sir.
So in disability adjusted life years, there are two components to this. Years lived, years of life lost due to premature death. Okay. And years of life lost due to disability. Okay. So now I give an example. Somebody has CA breast. Okay. At the age of 40 years. He lives till 50 years. But she lived for 10 years with disability. Okay, that will go into years of life lost due to disability. Now, if a person has a breast and died at 40 years, who was supposed to live till 50 years, that is the years of life lost due to premature death. Okay. Are you getting my point?
Yes, sir.
Okay. So what is DALI? One DALI is equal to one DALI is equal to 1 year of
Healthy life. 1 year lost of healthy life.
1 year of healthy life lost or life of health, yeah, healthy life lost. It can be lost due to a disability. It can be lost due to early death. Now, I want you to understand the concept of DALI. Because of that, I'll just ask you one more question. Here's a pain. One second. Yeah. Can the DALI, you just hear my statement and then answer. The DALI due to CA breast in USA is 20. The DALI due to CA breast in Pakistan is 20. Can this be true or false?
False.
Okay, some people saying false. Anyone else?
Can be true due to late diagnosis.
Okay. So what happens in late diagnosis? Okay, take Pakistan. What you diagnose CA breast at stage 4. What happened? The patient died early. But what happens in the US? They have excellent screening camps. They will diagnose the disease at stage 1. But the moment you diagnosed a patient at stage 1, the person has lost a year of healthy life. Right? Or stage 2, there was a breast lump and then you did screening, FNAC, all that, through cut biopsy. The person has been diagnosed with breast cancer and he has lost a year of healthy life. Having stage 2 breast cancer doesn't mean that he is having a healthy life, right? Anyone?
Yes, sir.
What I meant is, in DALI, there is 2 components. One is premature death and one is disability. Here, in developing countries, this will increase. In developed countries, the chance of this increasing is more. Patient will not die, but patient will live with that disability for a long time. Okay. Next, I want you to know is QALY. Quality adjusted life years. So what is QALY? QALY is 1 year of life. One QALY is equal to 1 year of life lived in perfect health. So why you use this is mainly for interventions. Okay. So I'm saying that to prevent road traffic accidents, you have 2 options. One is using the seat belt, and the other one is using the helmet. Okay. So people who use the seat belt had 20 QALYs, while people who use the helmet had 40 QALYs. So that means when helmets were used by these bike accident people, bike riders, 40 years of life lived in perfect health was more. They didn't have an RTA. The chance of having an RTA was less. So as a public health person, I would promote people who are riding bikes to use helmet. But apparently everyone in sitting in the car, they are protected already by the car. So even if you, I'm not saying all people who ride cars should not use seatbelts. That's utter rubbish. You don't want to prevent it, but as a public health person, if I want to reduce RTA, then I would like look at helmets to reduce uh, the burden of that disease. Okay, that is QALY. Then I want to, yeah. Then there is something this can be asked because it's very controversial, because there's something called the global hunger index. Anyone read the newspapers in the last 1 month or something? Anyone? Because in the last 1 month, the Indian government, Ministry of Health and Family Welfare, is denying that we are 107th among 121 nations. Okay. Even Pakistan is better than India. Do you like the statement? Do you like that statement? No, no. Okay, just imagine if you're the Ministry of Health and you see that Pakistan is better than India in global hunger index, and you are stated as 107th among 120 nations, you would not sit. What is the first thing that the government of India say? Global hunger index is bakwas. Don't believe it. But yeah, I don't agree with these idiots in the ministry. I will say that the global hunger index is really attributes to how much of hunger is there, because it looks under 3 parameters. One is undernourishment. Okay. Then 2 other things in children. That is under 5. Under 5, underweight. Okay. And the third one is child under 5 mortality. So these people have not taken data from their own studies or anything. They have taken the data from NFHS5, which is an Indian data. Okay. That itself will show how much is the undernourished, under 5 underweight, and under 5 mortality. India is the one of the most number one in. Can you tell me where we are lagging behind? In these three?
Nourishment.
Undernourishment. Undernourishment, we are talking about the total population. Okay.
Underweight.
Yes, yes, excellent. Under 5 underweight. This total population is okay in India. Undernourishment, not okay. I'm saying it's low. The undernourishment means proportion of people who are undernourished in the total population. That is the first point. Under 5 underweight means the total number of underweight among the under 5 children in the population. Mortality under 5 mortality is mortality of children under 5 among total under 5. So the problem is what is acute malnutrition? What is chronic malnutrition? What is underweight? All this. Can anyone tell me? How do you measure acute malnutrition? How do you measure chronic malnutrition? How do you measure underweight? Okay, I'll give you the excellent mid-upper circumference. What is that used for?
8.
Okay, if mid-upper circumference is less than 11.75 centimeters, it is malnourished. Okay, how do you check mid-upper circumference?
Shackle step.
Excellent, shackle stick. Wow, you students are really good. I don't have to teach, huh? Okay, fine. So there is something called weight for age, weight for height, height for age. Okay, height for age is stunting. Okay, what is wasting? Weight for height. This is wasting. Stunting is chronic malnutrition. Wasting is acute malnutrition. Right? If a child's height is very low, that means the malnutrition is for a short time or a long time.
Long time.
Long time. So that is a chronic malnutrition. Then for that height, if his weight is low, that means he is having an acute problem. Weight for age can be either acute or chronic. Okay, it may not be, it can be due to a long-term cause or it can be due to a short-term cause. And that is where your underweight proportion comes. Okay, so you are measuring weight for age. And how do you measure the weight for age in India? With what? In Anganwadis? Do you know something called the growth chart? Okay, the WHO growth chart. Okay, this is what you measure is the weight for age. Okay, something goes beyond 2 standard deviation and 3 standard deviation. What does it mean? Beyond 3 standard deviation is severe acute malnutrition. Okay. This is your growth chart. Now, beyond 3 standard deviation is the same thing in Shackel's tape. If it is below 11.5 centimeter in Shackel's tape, the same thing in severe acute malnutrition. This 11.5 centimeter is same as your 3 standard deviation on the growth chart. யார் அங்க calculate பண்ணிட்டு இருக்க? Listen to the class. Okay. சரி. Okay. So I know it's a bit, when I talk about statistics, you will understand what is standard deviation or not. Why we say that more than 3 standard deviation, why is it the extreme? Okay, when we talk about statistics. I'll come across that. Anyway, coming to the next point. Yeah. When you come to SAM, when you come less than 2 standard deviation, you call acute malnutrition. So what is the difference between using a growth chart and a Shackles tape? Can anyone tell? Anyway, you are going to do your MRB. You will go to Anganwadis, and the first thing the Anganwadi teacher will show you is, ஐயா பாக்கு இந்த growth chart என்ன பண்ணணும் சரியா? So then you say, oh, you use the Shackles tape, it is better. Why did you tell use Shackles tape to that lady? She has marked everything wrong, and it is marked wrong based on the age. She looked at the children and then she told, okay, age is this must be 2 years, this must be 3 years. I think she doesn't have birth certificate and all. I think this is 4 years. This girl, but actually that girl was around only 3 years. Okay. Yeah. Okay. So then you tell use Shackles tape. Why? What is the difference? Hello? Can anyone tell the answer? Mid upper arm circumference is the age independent anthropometric measure. Okay, what that means is anyone who comes with a value from 6 months to 5 years, a value below 11.5 centimeters, I would say it is severe acute malnutrition. Okay. Have you understood global hunger index? Why the Indian government hates the global hunger index and everything? Yeah. Hello.
Yes, sir.
Yes,
Yeah.
sir.
Yeah, before I go into measurements of health, yeah, there's one more class. Yeah, we're going to another beautiful part of epidemiology. Yeah, just go into the slide. Okay, so what we're going into epidemiology now. Okay, before we go into epidemiology, I want you to, okay, before that I'll give an introduction. So what is epidemiology? Anyone? We're going into a longer series. 7:30 we'll have our next break. Okay, what is epidemiology? Can anyone tell? Quickly, epi means among. Demo we all know, no? Demography. That is population.
Study of
And
spread and control of disease among population.
spread and control. Okay, no problem. So this is basically this thing. It's the study of distribution. I told you Jon Snow, right? What did Jon Snow do? He went around going knocking everyone's door. That is called shoe-leather epidemiology. And then, yeah, do you have cholera? Don't you have cholera? Do you have cholera? Don't you have cholera? So what did he do? He found the
Determination.
no, he didn't find the determinants. He's just asking everyone, do you have cholera? Don't you have cholera? Do you have cholera? And then he's marking on a spot map. So what is he doing?
Distribution.
Excellent. That's what I'm calling. Okay, thank you. Distribution of the disease. So study of the distribution. That's why he's called the father of epidemiology. Modern epidemiology is father of it. And determinants. What do you mean by determinants?
Factors.
Yes, all your risk factors of the disease in a specified population. And this part you don't need to know for your exam. These two terms I need to know, distribution and determinants, because all your study designs is based on that. Distribution and determinants, and that will decide how you as a public health person will control the health problem. Okay. Have you understood till now?
Yes,
sir.
Okay.
Yes,
Now
sir.
we are going to something called study design. Very important part of the chapter. I want you to listen very carefully. Okay, I just need a 7:10 we'll restart. I just want to drink some water, take a break because it's a long. I don't want to take a break in between study designs. Shall we
Sir.
take 4
Okay,
minutes break? Okay,
Okay, sir.
sure. Hello, hello, hello. Yeah, I'm sorry for the delay. I can see only 19 participants as of now. What is it? It's beginning. Are the 19 participants able to hear me?
Yes, sir.
Yes, sir. Yes, sir.
Excellent. Okay, fine. So I'm sorry for the longer break. But, study design is kind of a long session. Yeah. So when we talk about study designs, what do you think is a study design? It is a scientific process that answers. Yaruda Mama, sorry. Please mute yourself if you are talking to any of your relatives, because this is a very important part of the whole session. So I don't want any disturbances. Kindly mute yourself. If you have any doubts anywhere, please tell me. Okay. So what is a study design? It's a scientific process that answers your questions about a population by collection of data of that population. There is one population in front of you. Okay, like the Chennai people. And then you want to know what is happening in the Chennai people. That is your study design. Now, what I want you to understand in study designs is, if you remember something like this, you will remember everything in study design. There's nothing else to remember. There is a man, there is a coconut tree, and there is a house, and there is a kid. One minute. I'm having some disturbance. One second. One second. Yeah, sorry. So when you see this picture, there are three ways of looking at this picture. There is one man, okay, and he's a common man. What will the common man look at this picture and say? There is a boy, there is a man, there is a coconut tree, and there is a house. That is, he is describing it. It is basically descriptive. Okay. Hello.
Sir.
Then one person is there and he's like a critic. Okay. So the critic is doing what? He'll say, he will kind of analyze it. And what is he looking? He's looking, this child looks 2 feet away from him. This coconut tree looks like it is 2 feet height. It's a very short coconut tree. So he is having an analysis. Okay. And then this critic bows to the artist. Monsieur, he's a big artist with a mustache. And he says, okay, you don't like my painting? This coconut tree is small. Okay, then I will draw a huge coconut tree. Now happy? So what has he done? He has intervened. Okay, that's why I put the red color. Till there is a common man, there is the critic, he has not intervened into the population. Okay, he's not changed the painting, but the monsieur, the artist, he has intervened into the population and changed it. Hello? Yeah. One second. Please, Amma, ഭയങ്കര ഒച്ച അമ്മ ഭയങ്കര ഒച്ച രണ്ടുപേരുടെ ശബ്ദം കേൾക്കാം മൈക്കിൽ കൂടെ. അമ്മ കുറയ്ക്കുക, അല്ലെങ്കിൽ അപ്പുറത്തെ റൂമിൽ പോയി സംസാരിക്കാം. Yeah, I'm extremely sorry. Okay. Yeah. So then I come to the classification of study designs using this example. Yeah. Descriptive is based on time, place, person, right? I told this common man can say, looking at the painting, he can say, there is a sun in the painting, so it's sunrise, so it's in the morning. And he can say from this picture, maybe he can say it's Chennai, and these are people. So time, place, and person is your descriptive. Get my point? Hello guys.
Yes, sir.
Yes, sir.
Now when the critic comes, he analyzes. These are your analytic tests. What are the analytic tests? You have one, the ecological test, two, the cross-sectional test, three, you have the cohort, four, you have the case control, right? In all this, you can analyze better than your description, right? Now, the last one is your intervention studies. Intervention studies is whenever you have your study population, you are putting an intervention like a drug or a surgery. That is called as intervention trial, right? That is, the examples are your field trials. So in the field, you go and then you'll give the drug, or the community trials. In one community, you'll go and give the drug. And your most important is your RCT, right? What is RCT? I've already explained. Randomized control trial.
Randomized control.
Excellent. Okay. So in all this, always remember the first part is when in the descriptive part of your study, you are trying to formulate a hypothesis. And in your analytical study,
Test
you're
hypothesis.
testing a hypothesis. Okay. Will that hypothesis be true or wrong? Is what you do in an analytical study. Intervention study, you are confirming the hypothesis. Okay. Now talking about the time, place, and person. Okay. So what is an epidemic? What is an outbreak? What is a pandemic? It can be asked as an MCQ because COVID is an epidemic, pandemic, or an outbreak. Can anyone answer?
Pandemic.
Oh,
Pandemic.
very good. Excellent. So what is an epidemic? It's an occurrence in a community or region of cases of an illness or other health-related events clearly in excess of the normal expectancy. So if there is something like swine flu or H1N1, anything, H5N1, H1N1, sorry. And normally there will be some 2 people getting the disease. But suddenly 1 month, there were 30 cases of H1N1. Will you call it an epidemic? Hello? Yes. Another example is recurrence of an eliminated or eradicated disease. Like if you see a case of smallpox today as a medical officer, you'll call it an epidemic or an outbreak?
Outbreak.
You'll call it an epidemic because it is eradicated. There shouldn't be a case of smallpox ever. Okay. Or occurrence of a new disease with epidemic potential. Like in one case of Ebola you see in Chennai, you run and panically tell epidemic, 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 because it has epidemic potential. prevention. What is an outbreak? Outbreak is almost similar to an epidemic, but it is limited to a geographical area. So if you're taking Chennai, it's just one block of Chennai, and then there are chances of spreading to other blocks, but it's a smaller form of an epidemic. Okay. So if you have like 20 cases of cholera in your PHC, you call the other PHC. Okay, again, there is 10 cases of cholera. Then this 20 cases is your cluster of cases. But when you take 10 cases and tell everyone outside, then you say that there is an outbreak of cholera. Okay. Are you getting my point? So
Yes,
what
sir.
is pandemic? Pandemic is that which has spread to several countries. Okay. That is your in China jumped to all the American, Europe, and then come to India, everywhere, then we call it a pandemic. So next is your endemic. So what is the difference of endemic from the epidemic? What does it mean? This
Usually
year,
occurs in a single area.
pardon?
Usually confined to a single place, single location.
Yeah, it's a single location, so it's almost like an outbreak. But what there will be a constant presence. It's not in a more epidemic proportion, meaning 2 cases of H1N1, 2 cases of H1N1, 3 cases of H1N1. Like this is first year of your practice, then second year, then third year. All those in your PhD, the rate is like this. Then you say it is endemic. There is a constant presence of that disease, right? That disease has never gone away from your PhD, but it is confining to the usual prevalence of the disease or the infectious agent within a geographic area. Okay. Understood? Understood?
Yes, sir.
Yes. But suddenly in your PhD, 20 cases come. What do you call that? 20 cases come in 1 month. What do you call that? There is a cluster of cases. It can be an epidemic or an outbreak, depending on the situation. So what is hyperendemic? It is refers to the persistent high levels of disease occurrence. Okay, meaning there will be in 10, 10, 10, not 2, it will be 10, 10, 10. So, but it is localized to that geographical area. Sporadic refers to a disease that occurs infrequently and irregularly. Sometimes it comes up, sometimes it's never there, sometimes it just comes in one case. That is known as a sporadic disease. Okay, I'll give examples, then you'll understand better. Okay, anyone wants to answer? Read fast. 22 cases of legionellosis occurred within 3 weeks among residents of a particular neighborhood. What do you attribute that to? Can anyone tell? 22 cases. There is always only, like I told you now, H1N1, 1, 2, 1, 2, suddenly 22. What do you call that?
Cluster.
It's an
Epidemic.
epidemic. Okay, I'm not talking about your PhD. Okay, it's an epidemic. It's more than 2 standard deviations. Average annual incidence was 364 cases of pulmonary tuberculosis per 1 lakh population in one area, compared with a national average of 134 cases per 1 lakh population. The disease is always high, but it is constant,
Endemic.
not just endemic. See, look at the national average, it's 134. It's higher than that. It's excellent. Beautiful. Now you're getting the concept. I told you not 10. It's not 20. 10, 10, 10, 10. It's not 2, 2, 2. 2 is the national average, but it's 10, 10, 10, 10. So then you have to say this is a hyperendemic disease. Okay, confined to that place. Then over 20 billion people worldwide died from influenza in 1918 to 1990. What do you call that?
Pandemic.
Excellent. Single case of histoplasmosis was diagnosed in community.
Epidemic.
Outbreak.
No,
Sporadic.
just sporadic. It's an irregular thing. It's not, it doesn't have an epidemic potential, histoplasmosis. Something like if somebody said a single case of Ebola happened, yeah, I would say that it's an epidemic case. So you should know the disease also to decide if it's an epidemic or a sporadic case. 60 cases of gonorrhea usually reported in the region per week, slightly less than the national average. What do you call that? Concept. Where is the concept? Confined to a region equivalent to the national average.
Endemic.
Endemic. Ah, excellent. Very good. Now, as when you run a PHC, now do you understand why IDSP is important? Do you know what is IDSP? Anyone? Okay, there's something called, there's a national program in India called the Integrated Disease Surveillance Program. Okay, that is IDSP. What we do is there is something called the P form, L form, S form, and depending on the symptom is called the S form. L form is for the laboratory diagnosis. P is the presumptive form. Okay. So what happens in IDSP is, because see, this is important because once you join the PHC, you will be part of IDSP. That's why. When you get certain cases, or when your health worker goes to the village or somewhere, she collects cases, she will be collecting in the S form. Okay, that is the symptoms. She will be finding a cough for more than 2 weeks, that is tuberculosis. She cannot diagnose tuberculosis, but she can ask for the symptom of tuberculosis, that is cough more than 2 weeks, and she will give a report, and then you will think that this happens on a weekly basis, but IDSP has to happen on a daily basis. Okay, daily the data is going to you are also then diagnosing some cases. You also have to enter the data. Laboratory diagnosed are going into the L form. Okay, if there is a microbiologically diagnosed TB case, that goes into L form, and this will go into a huge data form. Okay, and with that, what is the advantage? Now, Shyam working in PHC 1. Okay, he reported 2 cases of cholera. Okay, PHC 2 is close by, and he reported 10 cases. And PHC 3 is Radha. Radha reported 10 cases. Now, when Sham looks at it, 2 cases, who cares? I would say it's endemic. But when you collect the data, you give data from a PHCs to everywhere, you get how much? 22 cases, and that can be an epidemic. Right. Now we understand the importance of IDSP. Guys? Hello. So now we have something called the IHIP, that is the Integrated Health Information Portal. And from this, you will have dashboards of where all the clusters are, hotspots. Okay. So in Chennai, if there is cholera, all these cases will come together in the data. And then within this day, 22 November, we know that there are 22 cases of cholera in and around this place. This is important for your future when you're joining. Okay, so this is the descriptive part. I want you to learn what is epidemic patterns that can be seen. Common source epidemic. What do you mean by common source epidemic? What does that mean? Anyone? Anyone? Is anyone listening to the class? Hello?
Hello.
From a
Yeah.
single
Yes, sir.
What does common source mean?
Common source.
Hmm?
be like a pond or a river.
So when your disease is agent is in one source, then you say It is common source. Okay. For instance, a well, and this well has cholera. This is common source.
Well,
Source is common, right?
yes.
Excellent. Okay, that is your common source. Now, in common source, there is two different. One is point exposure. Only there is one point at which there is exposure, and the pattern will be like this. It will be having a sharp rise and a sharp fall. It will just come and go. Before you know, it will come and the disease would have gone. And it would have finished in one incubation period. Okay. All the diseases will be within one incubation period. That is what we call common source point exposure. Okay. Hello,
Yes, sir.
you're understanding?
Yes, sir.
So
Yes.
when there is a well or a hotel, see, you will be investigating. As medical officers, you will have to investigate. Suddenly, there is one case of typhoid. Okay. Suddenly, within a span of 2 weeks, all the cases came down. So there is a common source. What is the common source? That's this hotel is the common source. And all the cases came down within that incubation period. That is called common source point exposure. Get it? I'm going to the next. So what is common source continuous exposure? It means that there is a common source, like a female sex worker. Okay, she has gonorrhea and she's having sex without condoms with man A, B, C. Okay, so once the disease founds, then another person has, like that, it can go, and then it comes down. Okay, so there is continuous exposure. It doesn't fall within one incubation period, because after one person had the disease, next person has like sexual contact with this female sexual, our next case comes. So it's a continuous exposure until that lady is treated and the other patients are treated. Okay, like that. Similarly, you have something called a propagator. Propagator is very simple. You just have to think about COVID. What happens in COVID is there is human to human transmission. Okay, right? COVID, there was human to human transmission, right? So what happens in propagator is it's not common source. One person gives to the next person. This person will give to the next person. This person will give to the next person. Okay, so there is a human to human transmission. It's not this person. This person can again give it to another person. Is it propagated? Hello?
Yes, sir.
Yeah, very good. Yeah, now tell me the answers to this. 21 cases of shigellosis among children and workers at a daycare center over a period of 6 weeks. No external source identified. Incubation period for shigellosis is usually 1 to 3 days. Propagated, or is it common source or is it propagated? First think that. Come on, come on, come on. Hello. Nobody wants to tell anything. Okay, I put the answer, sorry. So there's one child with shigellosis is transmitting to the next person and next person and next person. Now you should understand, is it within why did I say incubation period for shigellosis is 1 to 3 days? This is not within that 6 weeks. So the first is gone. It's not point source, right? Common source, point exposure, never, because it's not within the incubation period. Now it's shigellosis. You need to know about shigellosis to tell this. Shigellosis is a disease which keeps propagating between. It can be transmitted from one child to another child to another child. That's the thing of shigellosis. Okay. So that will be propagated, right? That's human to human transmission. Now next, 36 cases of giardiasis over 6 weeks traced to occasional use of a supplementary reservoir. So supplementary reservoir is your common source. Is it within, so you know it's common source, it's not propagated. So what incubation period is 3 to 25 days. So it's beyond your incubation period. So because it's beyond your incubation period, is it point exposure or continuous exposure?
Continuous.
Excellent,
Continuous.
it's continuous exposure. Okay. Then 43 cases of norovirus infection over 2 days traced to the ice machine on a cruise ship. Within 2 days,
Point
all,
exposure.
yeah, there was a sharp rise of cases within that incubation period. Point source, point exposure, common source, continuous exposure, common source, and propaganda. And leave this. Okay. Now you
one
understand.
doubt.
Yeah, tell me.
Sir, is typhoid as a point source or it is a continuous source, sir? Continuous exposure.
Typhoid, if one person is giving, the classic example of typhoid is Typhoid Mary. Okay. Typhoid Mary was a cook in America who was in a convalescent period. That means she developed typhoid and she herself was getting treated for typhoid. So what happens is the typhoid bacilli goes into your gallbladder and just stays there. Even if you get treated with typhoid, you don't show any symptoms. Your jaundice, everything goes back. So what she did was, once her symptoms go back, she'll go back to work. And she's known to cause, at least in her whole lifetime, at least 20 deaths and at least some 10 to 15 outbreaks. Okay. This one lady was responsible for 10 to 15 outbreaks and she caused at least around 20 deaths. Now, when she was giving typhoid, it wasn't within that incubation period. The people were not, it was going beyond the incubation period. So what will it be? The source is common. The source is the human carrier. That is Mary. She's common source. So it's not propagated. She is the common source for that epidemic. And it is beyond the incubation period. And hence, I would say it is a continuous exposure.
Okay, sir. Thank you so much.
Okay. Now that is part of your descriptive analysis, right? What are these epidemics? On what basis am I saying it's an epidemic? What is the single most important factor when I talk? Hello? Hello?
Transmission.
No, not transmission. Everything is important on that. It's important on a 4-letter word, time. Okay. When it is within this incubation period, when I'm saying that period, I'm talking about that time. Whenever it's within that time, I can say what kind of an epidemic pattern it follows. So that's why I would say like in life itself, time is one of the most important factors. Like you can't, like tomorrow you procrastinate. Okay, I'll study community medicine. I won't study today. Okay, obviously it's impossible. Till 11 o'clock is the class. You want to study the class more than 11 o'clock. Maybe, but tomorrow, then you lag behind. There's a chance for you to like lose the objective of this class. So time is a very essential component. Another part where time is important is when you talk about rate, right? Hello?
Yes, sir.
Another part of in epidemiology where time is involved is incidence. Okay. Another very important part of time in a natural history of diseases in your epidemiological triad. Okay. Because if time is involved in that, then only with time you can have an interaction between the agent, host, and disease. Okay, that's why I always tell all my friends, all my students, you can cheat this anyone, but you cannot cheat time. Time is something which is like something which controls everything around the sun, right? Anyone disagrees?
No, sir.
Okay, very okay, nice. Before that, I just want you to remember this is a short MCQ. Theories of disease causation. What are the theories that I told before? One is the miasma theory, all that is nonsense. Spontaneous generation. That is, if you have disease just starts on its own. You have a bottle, disease will increase on its own. It was given by anyone wants to answer? Aristotle. Okay. Then next theory was your spontaneous generation, then your germ theory of disease. Agent enters the host and causes the disease. Who coined the germ theory of disease? Anyone? Hey, come on, man. I have taught. Anyone?
Louis Pasteur.
Louis Pasteur. Excellent. Then next is your multifactorial causation of disease. Okay. So multifactorial causation of disease happen when disease. What happened is when we came to NCDs like diabetes or hypertension, we couldn't confine it to agent, host, and disease. We felt that there will be multiple factors causing diabetes, like smoking, age, elderly, hypertension. These are all part of the disease development in a diabetes. You cannot go into like a agent host disease. We can, but a better explanation would be multifactorial causation of disease, which was coined by Pettenkofer. Okay. Of Munich. Yeah. This comes from this place called Munich, but just remember Pettenkofer. So everyone sits around the prime minister. Who all sits? MPs.
MBBS.
Right. So this looks like a web. All the MPs sit like a web around it. And that is where your web of causation comes. That was given by McMahon and Pug or Pew. That is why MP. Easy. Now, why I put Pettenkofer of Munich is I wanted it as PM. Multifactorial causation of disease was coined by Pettenkofer of Munich, and web of causation is given by McMahon and Pug. Okay, now we go into study designs, the further aspect of study designs. I told you. This is the most important. Okay. You know this anyway. The risk I was telling about time is outcome is on the same time you are measuring. What do you call that? Anyone? Anyone? What study design do you call when you look at a disease and the risk and the outcome you look at the same time? Call it a cross-sectional study. Are you understanding?
Yes, sir.
Excellent. Now, you have the risk, and then you are going into the future and seeing the outcome. Of the disease. What is it? There is no disease in two groups. One has the risk, one does not have the risk. Then what do you call? What do you call it, Pa? Anyone? You call it a cohort study. But it is a prospective cohort study. Okay. Now the next one is you have the outcome. That is your disease. What is the disease? I told an example. I see a breast. And then you are looking at the risk factors. Then what will it be? Anyone, please?
Case control study.
Case
Case
control.
control study. Excellent. So you are going from the past to the backside. Okay. Now, one thing about prospective cohort study is it is time is an issue, right? I told time is always an issue. Most of your cohort study, you want to look at lung cancer, you look at smokers, right? And then you look at lung cancers. You'll have to wait at least 20 years. Okay, so for 20 years, I'm doing the study. It is never ending. And by that time, I can even die with a road traffic accident. Who knows? Okay, I don't know if smoking will cause lung cancer. So to prevent the shortcoming, what do? To cohort study. You can either do a case control study, but more powerful is a cohort study, meaning in the evidence-based medicine hierarchy, cohort study is better. So you can do a retrospective cohort. Okay. Can anyone hear me? Now the confusion is what? Yeah. I'll explain
Yes, sir.
because you're not getting the point. Okay. When I talk about studies, the cross section. Now you understood that picture, right? You saw that picture, right? What is happening is, I'll give you an example and then you'll understand. I'm looking at the prevalence of falls among elderly in Chennai in December. Okay. So what does that mean? It is at one particular point and it's risk factors. Okay. Now what happens is, at one particular point, I go to one house, I ask one man, you had a fall, yes or no? He will say yes or no. If he says yes or no, I will say, ask him what is his age, what is his gender, religion. Then I will ask, like, I feel that his visual disturbance All that I'm checking, but it's at one particular point of time, that is in December, and it's the prevalence, it's a proportion, and I'm taking one snapshot. Is there time involved? Is there time involved? Hello? Yes or no? Is there time involved? I'm going at one day or one day of December and then trying to find what is the prevalence. There's no time involved. Okay, so that is a cross-section study. Fine. Now, after that, I'll go to case control. Now, I'll take that example which we have always been discussing today. CA breast. Relatives, no CA breast. Okay. We'll go into Clapton's study itself. Okay. So there is disease, outcome is there. Outcome is there or not? Tell me, has outcome occurred? I am looking at cancer breast. What is the
Yes.
outcome? Disease. That is cancer breast. Now I'm going into their past history and asking their menarche. Okay, menarche. And that is late menarche. No, early menarche. I'm just taking one risk factor, late menarche. Among cancer breast, okay, now you have a 2x2 table. In this row is your early menarche. This row is late menarche. In this column, it is all your cancer breast people. Okay, this column. And this column is your no cancer breast. Okay. So whoever who was early menarche, all the cancer breast patients who had early menarche were around 20. But no cancer breast patients were around 5. Who had late menarche was around 5. And who had no late menarche, no cancer breast was around 10. Can somebody calculate the odds ratio?
$20.
A. How 20 man? It's odds ratio is what? AD into
Eight.
B's.
Piece.
No. So how much is it? 8. Hey, don't forget our max and all, okay? After becoming MBBS, don't think that you don't need max. So what does it mean? 8. So among lung cancer patients, among those who had early menarche, there was 8 times the odds of developing lung cancer as compared to those who had with late menarche. Are you understanding my point? So the outcome has occurred, and then you are going to the risk factor. It is always retrospective, going into the past, back in time. Have you understood till now, guys? Yes or no? No, guys.
Understood, sir.
Okay, excellent. Now there is another study called the cohort study. In that, you are looking at people with risk factor present and risk factor absent. So cohort is basically when there used to be in the Roman army, there'll be a group of people with the same characteristics. Okay. And if one group of army people are carrying the spear, they'll all be carrying the spear. The other group will be riding the horse. Okay, so they have some common characteristics. That is from where the word cohort came from. Okay, now in this risk factor, let's take smoking and no smoking. So there are two groups. You found 50 people who are smoking and 50 people are non-smoking. Now, after some 10 years, you look for lung cancer. Hello, are you following? Then among that 50 people, somebody said something. What is it? Are you following? Yes or no?
Yes, sir. Yes, sir.
Okay. Among the 50 people, 30 developed lung cancer. Among the non-smoking, 5 developed lung cancer. Okay. So in cohort study is the only place you can find the incidence. In cohort study, you will get the natural history of disease. How the disease has progressed. I told you in the beginning now that how the disease, there is always a interaction of the risk factor as agent, host, and disease, and then it eventually causes the disease. So the development of the disease you can see in a cohort study, never in a case control, never in a cross-section study. So now let's look at the 2x2 table in this same example. Always remember in the column you will have the disease whenever you are making a 2x2 table. C for D. Okay, C next comes the alphabet is D. In row is your risk factor. R for R. Get it? Yes, no?
Yes, sir.
Okay, now you have lung cancer. And the risk factor is smoking. What did I say? There is 50 smokers and 50 non-smokers. Among the 50 smokers, 30 developed lung cancer, 20 did not develop lung cancer. Among the 50 non-smokers, 5 developed lung cancer, 45 did not develop lung cancer. So now you have to find two things. What is the instance among exposed? Who is exposed? These are the exposed. Incidence of lung cancer among exposed is 30 people developed among 50 people into 100. That is 60. Next is incidence among non-exposed. What is the incidence of lung cancer? 5 people developed among the non-exposed. 50 people are non-exposed. So 10. So there is something called a relative risk. So what do you mean by relative risk? Relative to the exposed, non-exposed, relative to the non-exposed, how much chance risk of having lung cancer is there in the exposed? You're getting my point? Hello? Now, if the incidence of disease, if in the whole population, now this is a tricky thing, in the whole population, the chance of having the disease is 100%, what will be the relative risk? If every individual has the chance, has developed the disease, what will be the relative risk? If it is exposed, not exposed, whatever bullshit, then relative risk is 1. Meaning there is no relevance of the risk factor. But in this, the relative risk is incidence among exposed divided by incidence among non-exposed into 100. And that will give you what is incidence among exposed? 60 by 10 into 100. This has given you a positive value 6. So what will you say? When I say the disease relative risk of lung cancer is 6 among smokers, what does that mean? There is a 6 times chance of developing lung cancer if you are a smoker as compared to a non-smoker. Okay. Anyone understanding? Hello? Yes or no?
So can you explain relative risk again, sir? Just
Okay.
calculation part alone.
Calculation part alone, I'll come to them.
Okay.
You got the 2 by 2 table?
Yes, sir. Yes, sir.
Okay. So now when I say, it's just follow simple English, okay? Incidence of exposed among incidence of lung cancer among exposed. You guys understand Tamil, no? All of you?
Yes, sir. Yes, sir.
அப்புறம் நான் சொல்லுவேன், எவ்ரிஒன் இஸ் அந்த ஸ்மோக்கிங் பண்ணவர் அதுல எவ்வளவு பேருக்கு லங் கேன்சர் வந்திருக்கு? 50 பேர் இருக்கு மொத்தமா. 50 ஸ்மோக்கர்ஸ் இருக்கு, 50 நான் ஸ்மோக்கர்ஸ் இருக்கு. இனி அந்த 50 ஸ்மோக்கர்ஸ்ல எவ்வளவு பேருக்கு லங் கேன்சர் வந்து, அதுதான் இன்சிடென்ஸ் ஆஃப் லங் கேன்சர் அமங் த எக்ஸ்போஸ்ட். எக்ஸ்போஸ்ட் மீன்ஸ் அந்த பீடி, என்ன சிகரெட்டு, தம்மு அது பண்ணுதா எக்ஸ்போஸ் நம்ம சொல்லலாம். அது எவ்வளவு இருக்கு? 30 பேருக்கு லங் கேன்சர் வந்திருக்கு. 50 தம் அடிக்கணும், சரியா? into 100. 100 is just a multiplier. So you got 30 into 2, that is 60. Did you get that?
Yes, sir.
Okay, simple.
Yes,
Now, நான் சொல்லி 50 நான் ஸ்மோக்கர்ஸ் இருக்கு, 10 வருஷம் அப்புறம் தம் அடிக்க தம் இல்ல, ஸ்மோக்கிங் இல்ல, ஒரு 10 வருஷத்துக்கு அப்புறம் 5 பேர் அந்த 50 பேர்ல லங் கேன்சர் வந்தாச்சு. அப்புறம் என்ன? 5 people incidence of lung cancer among non-exposed. That is 5 people have lung cancer. எவ்வளவு நான் ஸ்மோக்கர்ஸ் இருந்து? 50 பேர் இருந்து. 5 out of 50 into 100. 100 is a multiplier. எவ்வளவு? 50 கட் பண்ணா 2 இருந்தா 5 into 2 10. Okay, got till now?
Yes, sir.
Yes, sir.
Okay. Ini,
Yes, sir.
now the word relative, what do you mean by relative? Oh, I am related to my girlfriend. I am his boyfriend. அதே மாதிரி தான் இது. நான் ஸ்மோக்கர்ஸ் இருக்கு, நான் ஸ்மோக்கர்ஸ் இருக்கு. அவரு வச்சு என்ன டிஃபரன்ஸ் இருக்கு, அதுதான் ரிலேட்டிவ் ரிஸ்க். How will I know how to know the difference between exposed and non-exposed? I just divide them. Correct da? Now I get a relation between them. Hello?
Yes, sir.
That will give you a risk. Okay, so when you divide that relation between incidence of exposed and incidence of a non-exposed, you will get, and you just multiply by 100 because it's a multiplier. So that will give you 6 by 100, 60 by 10 into 100. Leave 100. Okay, relative risk is IE by INE. Sorry, there's no multiplier here. You'll get 60 by 10. Cut the zeros, you'll get 6. என்னாச்சா 6 வாட்டி சான்ஸ் இருக்கு என்ன லங் கேன்சர் வரதுக்கு வாய்ப்பு, தம் அடிக்கணும் இருக்கு. Among smokers, there is a 6 times chance of developing lung cancer compared to non-smokers. புரியுதா?
Yes, sir. Clear, sir.
Yes, sir.
Okay, now I'm coming to another aspect that is called attributable risk. ஏன்னா ஒரு மனுஷனுக்கு லங் கேன்சர் வந்திருக்கு, ஓகே, அந்த அவரு சொல்லலாம் நான் ஸ்மோக்கிங் பண்ணும், நான் வயசான, I have become elderly, I am also drinking alcohol, then சென்னை தான், அங்க நிறைய ஏர் பொல்யூஷன். How can I say that if there is lung cancer in me, it is due to smoking? Can it be due to alcohol? Can it be due to air pollution? Can it be due to because of my age? அதுதானா attributable risk we get. So what you are trying to do is, there is incidence among non-exposed. Now this is tricky, okay, to understand. Incidence among non-exposed, what does it mean? That these people do not have smoking. Correct da? Correct da?
Yes, sir.
Incidence among non-exposed, but they are all exposed to these factors: air pollution, alcohol, elderly, right? Now I want to know how much is due to only because of smoking. That you find out by IE minus INE. Okay, in the exposure, when I remove these factors, elderly, alcohol, air pollution, from the incidence among exposed, then I will get only due to smoking. Then I can say, I can attribute it to smoking. Okay, புரியுதா? அப்ப இந்த ஃபார்முலா தெரியுதா? IE smokers, I am removing the incidence among non-exposed. Incidence among non-exposed என்ன? Elderly, alcohol, air pollution எல்லாமே இருக்கு. அதுதான் நம்ம மைனஸ் பண்ணிட்டு, then we are finding the relation between incidence among non-exposed. அப்ப இது என்ன? IE is what? 60 minus 10 divided by 10. என்ன இருக்கு? 50. You should multiply by 100. 50 by, oh wait, minus IE by 50 by 10. 50. IE is what? IE is 60, 10. Yeah, 60 minus 10 divided by 10. 50 by 10. Wait, 1 second. No? Let's start to. Can we take a break for now? I'm feeling a bit tired also. Just okay.
Okay, sir.
Yeah, we'll just take a break, a longer break, because it's been a long time. 15 minutes break. Okay, now. Yeah, I'm starting back the class. Hello. 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 Okay, so yes, okay, Sandra, okay. Yeah, so I'm really sorry about what I said. Like there was a small clarification in that, and in attributable risk, I'm trying to find out how much of the disease is due to that attribute or that risk factor, that is smoking. So this concept is saying among the instance of exposed, I'm removing the instance of non-exposed from that factor. That is all these factors I'm removing, and then I'm comparing it not with the non-exposed. I'm sorry, you're comparing it with the exposed itself. So this will have all smoking, elderly, alcohol, everything will be there, but in the numerator, when I minus from exposed and non-exposed, I will get only what I have due to smoking, right? In exposed, that person can have smoking also, elderly also, alcohol. So when I remove that factor, I will get the attributable risk. So when I'm really sorry, here it will be 60. 60 minus 10, 50 by 60 into 100 will be your, sorry, here will be 60 into 100. So 0, 0, and 60 minus 50 means 50 by 6. 6 into 500 by 6. 500 by 6 is how much? 6 into 8. No, 7, 48. 2, 6, 3. So 83% is due to attributable risk is due to smoking, I can say. So when I, in a population, when I remove smoking from it, 83% of the probability of lung cancer will be removed. Okay. Everyone, hello.
Okay, sir.
Okay, rest are all this 16% is due to his age, air pollution. Okay. That is the concept of your attributable risk. Basically, I'm really sorry, i.e. incidence among exposed, you're removing the incidence of non-exposed, that is all the other factors, and then finding among relation to that incidence among exposed. Did you get the concept, guys?
Yes, sir.
Yes, very good. Next, we'll go into, now you understood cross-sectional case control cohort.
Yes, sir.
Okay, then we'll go to one question. Then I'll understand if you have understood. Okay. Yeah. Just one single question. Then I will understand if you have understood the whole topic. A 5-year studies plan to assess the incidence. Keywords. Incident. I know this kind of question will not come for MRB, but there's a lot of concept in this question. So then you'll understand. Any time you'll, even a small question comes, you'll be able to, like, say this title this time. Okay. Incidence and etiology. You're looking of respiratory disease in 600 individuals greater than 50 years of age. The study consists of 2 groups. One group cares for a pet dog and the second group does not care for any animals in the household. At the onset of respiratory symptoms, cultures and serological studies will be performed. Which of the following describes the study design? So Your respiratory disease is your outcome. Risk factor is dog, yes, dog, no. And then you are following over a period of time to look for respiratory disease. What is the answer? What will it? Huh?
Cohort study.
Excellent. Very good. Now you understood the concept. Okay, just one simple question just to get that idea clear. Now we go to, before we go into, there is always a chance for bias in any kind of study. So what is bias? Bias is something which an error that can be due to the design itself. When you try to collect some data, there can be a design problem itself. Okay, so there are two types of bias. One is your selection bias. Okay, that is when I am the interviewer and then I'm taking information. I no I try to make sure that okay, I have some relatives and I know that there is drug A, and I know before the study itself I feel that drug A is good. So what will I do? I'll put my relatives with drug A and drug B is the placebo. So what will I do? I'll put drug B into the placebo. I'll put my non-relatives into the placebo group. Is that a bias? Yes or no? Yes or no? I know the drugs effects and I know who are the participants and I want my relatives to get that drug. So that is a selection bias. Okay. Then there is a information bias. Now supposing I come to a person with lung cancer and he says that I ask him, do you smoke? And he says, no, I don't smoke. Are you sure? And he's like, yeah, I've smoked one cigarette sometime when I was 10 years. Okay, then I say, okay, smoking present. Okay. And when I go to a non-lung cancer patient, I'll ask, smoking is there? I think so. Hey, are you sure? I don't think so. I don't know. So then I'll go to the lung cancer patient and say, you're a non-smoker. I'll be ready to, because I want that information that I have a pre-assumption that okay, this person is a lung cancer patient, this person will not smoke, so I will smoke, so I'll take that information. That is what types of main classification of bias in your collection of data. Did you get these 2 points?
Yes, sir.
Okay. Now in selection bias, there are different. One is the Bergsonian bias. So the probability of admission to hospital or detection of the outcome may be more among the cases simply because of the exposure factor itself. Okay. Now, what does that mean is, like, you take something like cholera. Okay. Now I am doing a study in cholera, and then I go to the hospital. Will the cases be high? Yes or no? Yes or no? Hello? 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 Okay, anyway. Now I go, instead of that, I go to the community, but I'm checking a cholera. The cases will tend to be less. So because I'm doing the study itself in the hospital where the admissions of cases are more, I might tend to say that cholera is everywhere. I have selected the patients only from the hospital. Is it a selection bias? I should have taken from the community also. Then I would said, okay, cholera is not so high. Just because patients have come to the hospital, I tend to say that cholera is high. Is that a selection bias?
Yes, sir.
Yes. Okay. Now, self-selection biases is that the only, it's almost similar to your Bergsonian bias, that only the cases in hospital are studied. No, like, uh, what about the cases that are in the community? They won't be selected. So you are selecting on your own. That is again another selection bias. Survivorship bias. What if there is a disease which is highly lethal? You want to do study among something like Ebola or some viral hemorrhagic fever like Ebola. You go to that place, you want to look at age, religion, blah, blah, blah. But patient is dead and in the cemetery. Can you go to that person and then ask age, religion, gender? He's already dead, right? Hello?
Yes, sir.
So you can only talk to all the alive patients. That is your survivorship bias. So what is incidence prevalence bias? That's another name is Neyman bias. You are excluding the patients who have died while will make the patients look less severe. Okay, same like your survivorship bias, but because you said Ebola, so many people have died. There are 10 patients of Ebola in the hospital, so it's not looking that patient is looking very, the disease is looking very severe. Then there is excluding patients who are recovered will make conditions look more severe. Like if those 30 people, only 2 people died. You have 28 people surviving, but most of them are in ICU. They didn't die. So you think to say that they're very severe compared to this disease, right? Depending on the incidence and the prevalence of the disease, it can have a change in your selection. So it's always, remember, it's always better to check incident cases, all the new cases that arise from your study point, rather than you go to a hospital and see what is prevalent. Okay. Now, what is Hawthorne effect? Okay. So the problem with me is whenever I take class in UG students, I feel that a lot of students are looking at me. So the moment the students are looking at me, I start acting weird. Okay. I will feel like very awkward. Okay. Then I'll start like talking less. As a teacher, that's not good. Okay. Now that is because of what? I am being observed by the student on me. Okay. That is your Hawthorne effect basically. Now I'm doing a study among clinicians. If those clinicians are using growth chart, okay, in the OPD. Okay, you are in the என்ன பிஹெச்டியில் இருக்கா அந்த டைம்ல நான் வந்து ஸ்டடி பண்ணேன். நீங்க growth chart யூஸ் பண்ணிருக்கா இல்ல? The moment I say I am coming, I am some district head officer, I am coming, what will happen to you? What will happen? I'm a senior officer, I'm coming, I'm doing a study. If you are using growth chart, what will you do? You will start using the growth chart, right? Otherwise that fellow will sack your job, right? So you changed, you never used to use the growth chart just because you came to know the district health officer with the health minister வந்து அவரோட பையன் MBBS பண்ணிருக்கு, அதுக்கப்புறம் அவர் ஸ்டடி பண்ண growth chart யூஸ் பண்ணலாம். ஸோ சீனியர் பர்சன் சன் இஸ் கம்மிங். ஐயோ நான் ஸ்டடி வரும்போது நான் எதுவும் பண்ணலாம்னா நினைச்சா போச்சு. கரெக்ட் தான். Will you change or will you not change? Your job is at stake.
Change.
Yes. And the information of that clinician will be wrong. You will think, oh, the clinician is perfect. He's using the growth chart for all the children. He's fighting malnutrition, nutrition. He's doing great for the PHC. Next is a recall bias. Where will you have recall bias? The person has to remember something. Where will you have this? In what study design will you have recall bias? Can anyone tell? So you're going to a patient.
Case control.
Yes, excellent. Case control will have recall bias because you are going to a breast cancer patient and then you are asking her, did you have menarche at age 4? And she's like, I think so. தெரியாது அந்த டைம்ல இல்ல 10 வருஷம் தான் நினைக்கிறேன். Oh, then you know. But if you are doing a cohort study, you got menarche at 10, that is early menarche, then you are following up them. There's no point, there's no place where you are trying to recall the information. அந்த பொண்ணு எவ்வளவு வயசு இருந்து என்னாச்சு என்ன, there's no question about it. You are already following up over a period of time. That is called recall bias, and recall bias is usually seen in this thing. In case control. Similar bias can happen in a case control. I am seeing a case control, case of breast cancer. அப்புறம் நான் சொல்லலாம், இதே பேஷண்ட் நீங்க எப்ப மினார்கி ஆச்சு? அப்ப அவர் சொல்ல 5 வயசு. அப்போ நான் ஐ நோ தட் இஸ் அ பிரஸ்ட் கேன்சர். கரெக்டு தான். 5 வயசுல கொஞ்சம் கூட 4 வயசா? இல்ல இல்ல நீங்க பிரஸ்ட் கேன்சர், நீங்க மினார்கி கொஞ்சம் கூட 3 வயசா? ஓகே 3 வயசு. 3 வயசுல எல்லாம் யாருமே மினார்கி நினைக்கல. பட் since you know it's breast cancer, you will tend to like push the age. So that information is changing. Right. So that is also another bias which can be seen in case control. Now next is something called attrition bias. இதெல்லாமே இங்கிலீஷ் தான், வேற எதுவும் இல்லை. attrition நினைச்சா what is the loss to follow? இனி நான் எப்பவுமே இந்த யூஜிசி கிட்ட கிளாஸ் இருக்கும்போது நான் சொல்லுவேன், இஃப் யூ ஆர் டூயிங் அ கிளாஸ், யூ ஆர் டூயிங் ஸ்மோக்கர்ஸ் அண்ட் நான் ஸ்மோக்கர்ஸ். ஏன்னா அவரோட ஹாஸ்டல் யூஜி ஹாஸ்டல்ல ஸ்டடி நடத்துறாங்க. ஸ்மோக்கர்ஸ் அண்ட் நான் ஸ்மோக்கர்ஸ்னா அவரெல்லாம் லங் கேன்சர் வருதா இல்ல பார்க்கலாம், ஆர் நோ லங் கேன்சர். ஓகே, திஸ் இஸ் த அவுட்கம் தட் யூ ஆர் ட்ரைங் டு ஃபைண்ட். என்ன நடக்குது? ஒரு 20 வருஷம் கழியும்போது நாம இப்ப பெங்களூர் தான். will all these students be in Bangalore? சில பேர் சென்னை வருது, பரவாயில்ல கால் பண்ணிடலாம். சில யூஎஸ்ல எல்லாம் போகுது, யூஎஸ்ல அவரு நம்பர் எல்லாம் சேஞ்ச் பண்ணிருக்கு. அப்ப என்ன அவரை பார்க்கறதுக்கு கஷ்டம். ஆனா ஸ்டடியில he was a non-smoker, but he has gone out of the country and you cannot understand if that person has lung cancer or lung cancer is not there. I don't have his number and the friend call பண்ணி அவரும் தெரியலன்னு சொல்லணும். So where will you see attrition bias? Where there is fallout.
Cohort study.
Excellent. Cohort study தான் வருது. Okay. Last in study design, I want to explain one last study design. அதுக்கப்புறம் biostatistics கொஞ்சமே சொல்லலாம். RCT. என்னதான் RCT? நான் சொல்லியிருக்கேன் ஆல்ரெடி. randomized control trial. Control acha intervention, we are giving a control to the people. Randomized acha randomization. Each person of that, Each individual has an equal chance of being in the, there will be two groups, experimental group and the control group. You have equal chance. If I'm a participant in an RCT, I have an equal chance of either being in the experimental group or in the control group. Okay. Purida.
Sir.
Okay. Ini experiment it can be a drug. ஒரு ட்ரக் இருந்தா ட்ரக் ஏ கண்ட்ரோல் குரூப்ல பிளாசிபோ அதுக்கப்புறம் ஃபாலோ அப் அப்புறம் தான் அனலைஸ் பண்ணி you will find if there is a if drug A is better than for treatment analysis follow பண்ணிட்டு outcome பார்க்கும் சரியா it can be cure or death அது அனலைஸ் பண்ணும் drug A is good for MI அது இன்டர்வென்ஷன் பண்ணி நம்ம ட்ரை பண்ணும் okay in an RCT always remember the person has randomization is the heart of the study so நான் ஒரு RCT பண்ணியிருக்கேன் வெள்ளூர் இருக்கும்போது அது என்னாச்சா நம்ம லேபர் ரூம் தான் some people were done stripping அதுக்கப்புறம் நார்மலா நம்ம வெஜைனல் ப்ரொஜெஸ்ட்ரான் எல்லாம் போட்டு பிஜி ப்ரோஸ்டாகிளாண்டின் அதெல்லாம் போட்டு அதெல்லாம் நார்மல் தட் இஸ் அ ஸ்டாண்டர்ட் ஆஃப் ட்ரீட் ஆனால் ஒரு கிட்டத்தட்ட ஒருத்தருக்கு வாட் வி வர் டூயிங் வாஸ் வி புட் த கேத்தீட்டர் யூ நோ த ஃபோலிஸ் கேத்தீட்டர் அண்ட் வி ஜஸ்ட் டைட் இட் டு அ 2 liter not 2 liter ஒரு வாட்டர் பேக் ஸோ இட் வாஸ் லைக் mechanical dilatation. That was our experiment. Who will get the mechanical dilatation and who will get the normal is based on randomization. So it is the person who is doing the study will open a letter and like ராதா வந்திருக்கு நம்ம ஒரு லெட்டர் ஓபன் பண்ணிட்டு அந்த லெட்டர்ல செக் பண்ணும்போது ஓகே ராதா எக்ஸ்பெரிமெண்டல் குரூப் போனோம் சரி அப்ப என்ன randomization will prevent selection bias ஏன்னா ஐ ஹவ் ராதா வந்திருக்கு ராதா என்னோட மாமா பொண்ணு என்ன அப்போ நான் என்ன ஓகே ஐ நோ தட் மெக்கானிக்கல் டைலேஷன் கொஞ்சம் வலிக்கும் ஐ டோன்ட் வாண்ட் ராதா டு ஹேவ் இட் கேன் ஐ டூ இட் ஹியர் நோ பிகாஸ் ஐ ஆம் ஓப்பனிங் எ லெட்டர் and then seeing okay Radha mechanical dilatation பண்ணியே ஆகும் I cannot decide that okay Radha என்னோட மாமாட பொண்ணு அது சேஞ்ச் பண்ணும் no that is not what happens in RCT that is why RCT in evidence based medicine in the hierarchy it comes above than case control cohort எல்லாமே are you understanding
Yes, sir.
okay now there is something called crossover RCT. Now, நான் சொல்லி ராதா இருக்கு ராதாக்கு வலிக்குது but I am thinking that maybe you know that experiment is good also. So what happens in RCTs, crossover RCTs, 10 people go into experimental group, 10 people go into control group. Crossover RCT you will allow the control group to be entering the experimental group and the people in the experimental group will go into the control group and this is called the washout. You will wait for at least 3 months for the effect of that drug to come out from the experimental group. This is when you know. So what happens is each becomes the control, even if the experiment is good, control will also have a chance to have the experimental drug. So it's a win-win, right? That is what happens in a crossover RC. Now we'll go to screening. Yeah, what is screening basically? Screening ஒரு நம்ம ஒரு ஐஸ்பர்க் ஃபினாமினன் சொல்லிட்டு ஒரு விஷயம் இருக்கு. ஆனா ஐஸ்பர்க் என்ன இருக்கு, இந்த மாதிரி கீழே ஜாஸ்தி மேல கம்மி. What does that mean? Iceberg phenomenon. மேல இருக்க inapparent disease. இல்ல inapparent அல்ல, sorry. Apparently deceased person. Deceased person. இங்க இருக்கிற எல்லாமே கிட்டத்தட்ட if you are taking something like COVID தானே இருக்கு. People who became COVID positive is very less. No, this is the inapparent portion. நிறைய பேர் சிம்டம்ஸ் இருந்து டெஸ்ட் பண்ணியாச்சா இல்ல, சப் கிளினிக்கல் டிசீஸா இருக்கு. இதெல்லாம் கீழே தான் இருக்கு. So whenever you try to find a disease, you will find out that only a small portion of the disease is being diagnosed and a large person is submerged. That is the inapparent disease. So நம்ம screening பண்ணது யாருக்கு? It is for the submerged portion. இதெல்லாம் நார்மல் டயக்னோசிஸ்ல இருக்கும். புரியுதா? Hello.
Sure.
Okay, so what is the level of prevention in screening? Screening S-ல எவ்வளோ டிசீஸ் வந்திருக்கா இல்ல? நம்ம டயபெட்டிஸ்க்கு ஸ்கிரீன் பண்ணும்போது என்ன நடக்குது? டிசீஸ் இருக்கா இல்ல செக் பண்ண சொல்லுங்கய்யா. பிரைமரியா என்ன எல்லாமே சொல்லிட்டு தெரியும். செகண்டரி தான். ஓகே, secondary level of prevention. When I'm screening, I'm doing a health camp. I finished my MRB exam. I became first rank. Now I've started the screening camp. Cataract screening பண்ணுவாங்க. அப்போ கிட்டத்தட்ட 20 பேர் ஸ்கிரீனிங் இருக்கு. ஸ்கிரீனிங் பண்ணும்போது 20 பேருக்கு கேட்ராக்ட் இருக்கு நினைச்சு you got the diagnosis of cataract in 20 patient. 20 பேருக்கு கேட்ராக்ட் இருக்கு. டிசீஸ் வந்திருக்கா இல்ல?
This is present.
So then it will be primary or secondary?
Second.
Excellent. Early diagnosis and treatment. Okay, it will be part of secondary. Oh. Please listen carefully. Okay, these are all concepts. I'm not telling any facts because the time is very low. No point in talking about facts. Precision. Okay, என்ன precision? Consistent results when repeated more than once. நான் என்னோட டிபார்ட்மெண்ட்ல கிளாஸ் எடுக்கும்போது நான் சொல்லி ஒரு டாட்ஸ் எல்லாம் போடும்போது நம்ம டாட் போடும்போது எப்பவுமே ஒரு you are hitting the same spot but you are not hitting the center. That is what you call precision. Consistency. என்ன தப்பா போட்டிருந்தாலும் you are consistently hitting it. Okay, நான் accuracy ஆனா அந்த ட்ரூத்துக்கு the truth is the center. If you are hitting the center, that means accuracy is high. Okay, so when I was taking this class on screening for some physiotherapy students, so apparently we had done a test on community medicine and everyone was getting 20 out of 60, others 19 out of 60, and another one is getting 20 out of 60. So that physiotherapy students told, sir, all community medicine teachers, when they correct, their accuracy is low. Why? They are saying that all our marks are supposed to be 50, 55, 50. Okay. But your precision is high. You are always giving us 20, 19, 20, 20. We are consistently failing the students. But for them, they feel that we are not valid. We are not close to the truth. We should have passed all of them. Bullshit. Anyway, now do you understand the difference between precision and validity?
Yes, sir.
Okay. Now there are two components in validity. This is very important. This can be asked in a question. That is, what is sensitivity and specificity? Okay. Sensitivity என்னச்சா நம்ம ஒரு 100 சென்னை நீங்க பிஹெச் இருக்கு, அந்த பிஹெச் இது ஒரு 1000 பேர் இருக்கு. ஓகே, அந்த 1000 பேர்ல கோடு வந்து நீங்க அங்க இருக்காங்க டாக்டர் தான். அப்போ அந்த டைம்ல கோடு வந்து நான் ஒரு டெஸ்ட் சொல்லி அதோட பேரு நான் நினைச்சா a rapid antigen test. Okay, now I have the test. You as a physician, you are going to the 1000 people in Chennai. Now in your 1000 people, very important, okay, listen very carefully. Now 1000 people, look at the screen. Actually, okay, 1000. Actually, 80 people have the disease. Or let's make it easier. And 100, you are taking only 100 people, okay, not 1000. 80 people disease, 20 people do not have the disease. I told you, now column will always have the disease, even when you are looking sensitivity and specificity. Now, test panniyappo, in 80 people, I got 70 positive. Anna, rest 10 negative. In the 20 people, I got around 10 positive, 10 negative. So now, what am I saying? I have 80 deceased. Adila, with this rapid antigen test, I got 70 positive. I was able to correctly identify 70 people. 10 பேரை மிஸ் ஆகி போச்சு. ஆனா 10 பேருக்கு டிசீஸ் இருக்கு. ஆனா but I am not able to get all that 80 people. No test in this world can find out that everyone's disease. Now, some people may not be having adequate viral particles. Virus will not be adequate, and because of that, that test will not be able. So, what is that 70? It is your true positive. Okay. So, among 80 people who have deceased, positive எவ்வளவு 70 people. And is it true that those 70 people are positive?
Yes, sir.
That is why it's called true positive. So the ability of a test to identify correctly all those who have the disease is called true positive. So, and now denominator first. So leave true positive, leave the denominator. Now next, இந்த டிசீஸ்ல 20 பேருக்கு டிசீஸ் இல்ல. ஏன்னா அதுல 10 பேருக்கு டிசீஸ் இருக்கு நினைச்சிருக்கு. பட் அது 20 பேர் டிசீஸ் இல்ல. அந்த 20 பேர்ல 10 பேர்ல டிசீஸ் கூட இல்லாத டெஸ்ட் பண்ணி கண்டுபிடிச்சிருக்கு. ஸோ இந்த பேஷண்ட்ஸ் who are 20, you got 20 na, அதுல 10 வேறு நெகட்டிவா இருக்கு. கரெக்டா பண்ணிருக்க, ட்ரூ நெகட்டிவ். It is, the test is negative and that is true. That means that person does not have the disease. Correct da? True negative, true positive, you got it?
Yes, sir.
Okay. Now go to the top. And the positive ஆச்சு. See, you should read the row. Row is the test. Test is the positive. Now these 10 people are positive, but they don't have the disease, so then it is called false positive. Okay. Next, in the row பார்க்கலாம் negative. அப்ப test negative வந்திருக்கு, but it is false, so then it becomes false negative. Okay, so I'll just draw the diagram once more. Yeah, now I'll draw the table, then it will be easy. இந்த disease இருக்கு, இந்த test இருக்கு. Test positive வராம், negative வராம். Disease present இருக்கலாம், absent. அப்ப disease இருக்க, test positive, that will be true positive. Disease இல்லா, this test is negative, that will be true negative.
True negative.
Disease test, disease இல்லா test positive வந்திருக்கு, அது false positive.
False negative.
Disease இருக்க, but the test is negative, so it's false. So what is sensitivity? How much is the total people who have the disease? That is 80 from that previous example. No, but among that total 80, and the column total are 80. So what is that 80? True positive plus false negative. அதில் எவ்வளவு பேரு true positive into 100. Got my point? Okay. So in this example, I had put 70 by 80 into 100. Now 8, 5, 2, 4, 130, 535, yeah, 85. So 85%. What does that mean? ஒரு 100 பேர் வந்து 100 பேர் டிசீஸ்ட் ஆச்சா அதுல 85 பீப்புள்ல பாசிட்டிவ் வரும். இந்த ரேபிட் ஆன்டிஜன் டெஸ்ட் யூஸ் பண்ணியா. You got my point? Okay?
Yes, sir.
Sensitivity. Sensitivity, specificity ன்னு சொல்லும்போது, how will the disease identify correctly those who do not have the disease? True negative among those who do not have the disease. That is false positive plus true negative. Correct da? True negative எவ்வளவு வந்து? What is it? 10. You know 10. And false positive plus true negative, you can see the previous one. 10 by 20 into 100. 20 into 50. So, அது என்ன? 100 பேர் இருந்தா 100 பேருக்கு கோவிட் இல்லைன்னாச்சா அதில் 50 people will the test be able to say it is negative. Rest of the 50 people who do not have the disease, it will show as positive. Are you understanding?
Yes, sir.
Okay.
Yes, sir.
Okay. So what is predictive accuracy? Predictive accuracy is a part of screening. Okay. Now in the same 2 by 2 table, there is positive test and negative test. Okay. Now positive predictive value means it is an inherent property of that test itself. It's not about the disease people எவ்வளவு பேருக்கு டிசீஸ் இருக்கு டிசீஸ் இல்ல அதெல்லாம் இதுதான் சம்பந்தம் இல்லை சரியா it is a part of that disease itself okay now when you talk about positive predictive value among the positive ஒரு டெஸ்ட் பாசிட்டிவ் வந்தாச்சா now if I'm going to a hospital I go and say that I want to do a test for COVID and then I do the rapid and RT-PCR and it came out as positive. I tell them, no, I don't have cough, I don't have any sputum and I'm not having fever. What can the doctor say? He can comment on the positive predictive value. In case this test come positive, what are the chances of you having the disease? புரியுதா? You're getting my point. Hello?
Sir, can you repeat again?
Yeah, okay, fine. You are sitting in the PHC, one person comes, okay, your best friend, and he comes and you tell, okay, do this test. நான் கோவிட் டெஸ்ட் ஆர்டிபிசிஆர் வந்து நான் டெஸ்ட் பண்ணும்போது நான் அந்த டெஸ்ட் பாசிட்டிவ் வந்து அண்ட் யூ டெல் யுவர் ஃப்ரெண்ட் நீங்க பாசிட்டிவ் ஆச்சு கோவிட் அப்போ நீங்க ஃப்ரெண்டு சொல்லு இல்ல நான் கண்டிப்பா பாசிட்டிவ் தான் நீங்க டெஸ்ட் தப்பு தான் அப்போ நீங்க சொல்லும் இந்த பாசிட்டிவ் ப்ரெடிக்டிவ் வேல்யூ 90%. அது என்னாச்சா 100 பேர்ல கோவிட் வந்தால் 90 times 90 people it will correctly identify as positive. 10 people it will not be able to say it is positive. It will wrongly diagnose a non-COVID person. Okay. I will tell you the whole thing with this thing, the 2x2 table, then you will understand better. Okay. Test பண்ணியாச்சு. One second, I will just you have a 2x2 table. Okay. Disease present, absent. Test positive, negative. Okay. True positive இருக்கு. Among the disease, if it comes positive, it's true positive. Positive on the disease illa, it becomes false positive. Okay. Either false negative on the, but they have the disease. This is true negative. Now you have to look at this part. Positive predictive value or test positive on the it will be true positive divided by true positive plus false positive. When I say 90% is my positive predict value means ஒரு 100 பேர் வந்தா 90 10 10 people will be false positive. That means patient has 10 people, the test has come as positive for 10 people, but do they have disease? Yes or no? No. So when I say 90% is the positive predictive value of RT-PCR, it means that positive acha 90 in 100 people, if I do of people in 100 people, it comes positive, 90 people will have the disease, 10 people will not have the disease. So you have a 10% chance that you don't have the disease. Test has come as wrong. Now you understood? Now this is another thing, negative predictive value. This is very important because in your PHC you will always use all this positive predictive value. ICU you will go to the CHC, you will do a D-dimer test. Okay, ICU CHC district hospital you will do a D-dimer test. எதுக்கு D-dimer test பண்ண? Hello. ICU patients when they have breathlessness அதெல்லாம் வரும்போது என்ன நம்ம ஒரு D-dimer டெஸ்ட் பண்ணலாம்.
For blood clotting இருக்கான்.
Clotting இல்ல. Sudden one patient is having respiratory difficulty, tuck tuck tuck, என்ன நடக்குது தெரியாது, அவரு பெட் ரிடன் ஃபார் லாங் டைம், டிவிடி வந்ததுக்கு அப்புறம் கிளாட்டிங் மேல வந்து லங்ஸுக்கு வந்து பல்மனரி எம்பாலிசம் வந்திருக்கா இல்ல செக் பண்ணதுக்கு. Now there is a test you can do, is you can do a CT, HRCT, but you just want to sit in the ICU and say that, okay, I want to rule out pulmonary embolism. Okay, அப்பதான் நம்ம ஒரு D-dimer டெஸ்ட் பண்ணி அது நெகட்டிவ் வந்து, now the D-dimer test negative predictive value is around 90%. What does that mean? Now look at this portion. Okay, this portion, if among the negatives, அந்த 100 பேர்ல நெகட்டிவ், அந்த 100 பேருக்கு நெகட்டிவ் வந்தால் 90 will be true negative. That means they don't have the disease and the test has come as negative. And now, but 10 people will have the disease, but it is false. That means the negative test has become negative, but that person actually has to be a true positive. So when the negative predictive value is high, நம்ம D-dimer பண்ணி patient negative வந்து, what can I say? He does not have, the chance of him having pulmonary embolism is very, very low. Are you understanding? But if it comes positive, I cannot comment because the positive predictive value of D-dimer is very low. It's around 40 to 50. What does that mean? 50 is the positive predictive value. That's positive வந்து அப்ப என்ன, maybe the patient can have the disease. 50 and the 50 times positive has the disease, 50 times may not have the disease. But the negative predictive value will help you to rule out. Negative on the, oh, okay. Positive on the, okay, I can't decide what to do. But negative on the, okay, let's wait on the HRCT. You don't have to do the CT fast. Purida? Have you understood negative predictive value also?
Yes, sir.
Okay, excellent. Leave this example. I'm going to just. Okay, wait. We need to know this. Yeah. Now this is one concept, lead time. Lead time என்னச்சா, நம்ம ஸ்கிரீன் பண்ணும்போது ஏன்னா ஒரு CA cervix நம்ம சொல்லுவாங்க, அது எப்போ நடக்குது, மெனோபாஸ் ஏஜ் குரூப் லேட்டர் ஸ்டேஜ் ஆகும்போதும், அது ஸ்டேஜ் 4 லங் கேன்சர், ஸ்டேஜ் 4லலாம் நம்ம யூஸ்வலா அவரெல்லாம் பெருசா ப்ளீடிங் எல்லாம் ஜாஸ்தியாகி அப்போ ஹாஸ்பிட்டல் வரும்போதும் is that diagnosis of usual time. புரியுதா? Now instead of that, you did a screening camp in Chennai, Kodambakam, anywhere near in Chennai, somewhere you do Marina Beach. Okay, near the beach you decide, okay, I will do a screening camp for CA7. Impossible, they will throw you out. Okay, just imagine. Now you diagnosed patients, ஏன்னா அவர் ஸ்டேஜ் 4ல diagnose ஆகுது ஒரு 5 வருஷத்துக்கு அப்புறம். But now you stage on the CIN stage 1 தான், when you are able to stain using glucose iodine or VIA, play in the டக்குன்னு நான் நினைச்சேன் ஓகே இது கண்டிப்பா சிஎஸ் சர்வீஸ். யூ கெயின்ட் த டைம் between normal diagnosis. Normal diagnosis it will continue till stage 4, then it will come to your PHC. அப்பதான் நினைச்சேன். But because you did the screening, you have diagnosed it early. And the time difference between the usual diagnosis and the time taken during your screening is your lead time. Understood? Hello?
Yes.
Okay. Now you understand the advantage of lead time. You should all do screening camps. Okay. எல்லாமே MRB பாஸ் பண்ணி ஓகே ஃபினிஷ் நினைக்காத. யூ ஹாவ் a lot of work to do. Okay. So now this is what lead time is. I told already before screening and after screening. Now, what is lead time bias? Lead time bias ன்னு சொல்லும்போது நான் இது காமிச்சேன் 2010. Okay. 2020. One person was diagnosed in 2018 and he died in 2 years in a lung cancer. Okay. நம்ம screen பண்ணி you diagnosed it at 2015 and you said patient survived till 2020. Survival years is 5 years. Screen பண்ணிய போதும் 5 years. Diagnosis 2018 பண்ணியாலும் அவரு 2020ல அருந்துட்டு போகும். அதுதான் 2 years survive பண்ணு. This actually the person would have died in 2020 even if you have screened or not screened patient that and the disease screen பண்ணியாலும் there is no difference. Even if he gets a treatment early, it doesn't make a difference. This bias which forms the survival time increasing because of your screening is called, see actually same 2020 he is dying anyway. Screen பண்ணியாலும் diagnose பண்ணு. But you are thinking the person has survived more. That has happened only because of your screening, and that is called a lead time bias. Okay.
Okay, sir.
Now we'll go to ಸ್ವಲ್ಪ biostatistics. Then we'll go into all this more. So what is biostatistics? Any idea? Hello? It is the application of statistics into biological sciences. Okay. So before you go into biostatistics, you should know something. Oh my God, what is that? Not here. Somewhere in Chennai. Thank God. Hope you are all fine. Anyway, application of statistics into biological science. Okay, that is basically your biostatistics. This I want you to know because whenever you are doing a study, it's very important. What is a variable? Any idea? What is a variable? Hello, hello, hello. Oh my God, where is that sound from? Anyway, yeah. So what is a variable? Variable is anything which you can measure. Okay. So it can be something like qualitative or quantitative. Okay. Listen carefully. So qualitative means mostly your yes, no questions. Like, are you happy today? Yes, no. Do you feel uneasy? Are you moody today? These are all qualitative. What is the stigma associated with leprosy? Can I like measure it in like a measuring cup? No. Those are your qualitative variables. But something like height, weight, those can be measured. You have scales, right? You can get 145 centimeter, 200 centimeter. Okay, so those are like quantifiable variables. They are quantitative variables. Now, in that, then the other way of looking at variables is it continuous variables or is it discrete variable? What does continuous variable and discrete variable mean? Any idea? The variables will have in between values. Like what? Like your height itself. There is 106.5, there is 107. So there are in between values and they are continuous. Discrete values are like, there are no in between values. Like take ABO blood grouping. There is no A.5. There is A group, B group, O group, AB group. These are all discrete. You get my point?
So,
Yeah. Then there is dichotomous and polyautomous. Okay. So what does that mean? Dichotomous means there are only two outcomes or two variables. Only two values it can, the variable can have only two values. For instance, RH. What can it be? Positive, negative. Right? Or gender. Now gender has many uses, but for research purpose, male, female. Polyautomous is like your again ABO blood grouping. There are more than two values that variable can have. I 5 minute break. Okay, not more than that. We'll just take a break.
okay.
అమ్మా అమ్మా మా ఇంటికి వచ్చాము. Yeah. Hello, we'll continue the class. So now when you know about variables as such, wait, where's my share screen. Okay. So now when you know that the variables are like this, then only you'll be able to talk about all the other parts of your statistics. Now, there are something called measures of central tendency. What that means is how your values are distributed around a central value. Okay, that central value is what you want to know. Okay, that can be the mean, median, or the mode. Mean is your arithmetic mean. Median is the middlemost value. You will arrange the values from ascending to descending and then look at the middlemost value. That can be your n plus 1 by 2. That is, if you have odd number of this thing, 11 is an odd number. If you have 11 values, 11 plus 2, 11 plus 1, 12 divided by 2. The sixth term will be a median. Mode is the highest value. Now I want you to look at one example that I want to give. I have 4 values, 1, 2, 2, 3, 2. Okay. Now what is the mean? I'll just take an average. 1, 2 equals to 5, 5 plus 5, 10. 10 divided by 5. The mean is 2. While the median is the middlemost value. 1, 2, 2, 2, 3. The middlemost value is the median. while the mode, the highest occurring, and that is 2. Are you getting?
Okay, okay.
Now,
So
just
the mode is like it should be repeated like more
Yes.
number of times, not
Yes,
the
yes.
highest value.
No, not the highest
Okay.
value. It means
Okay,
that
okay.
the highest occurring, sorry, I meant highest occurring. How many times that value will come in the this? Okay. Now, when I decide to change one value to 3 to one value 60, what has happened? What will happen to the mean? It will become 60 plus 65, 65 plus 3 is 68 divided by 5. That is 1, 13, something around 13. Okay. But what has happened to the median? You arrange it in order 1, 2, 2, 3, 60. So 2 is your median.
Median.
And mode, highest occurring is what?
2.
2. So what has happened? One value changed. That is called your outlier. If in a data set, if there is an outlier, your mean is always subject to change. The best value to take if there is an outlier is the mode, but to do statistics is difficult to use it, and that is why the most convenient when there is an outlier like this is the median. You use the middlemost value. Okay. Next we go into yeah, distribution. Okay. In distribution, there are two types, basically normal distribution, since you know mean, median, mode also, and there is skewed distribution. Okay, so what happens in normal distributions? You have a bell-shaped curve. Okay, you have heard all this, no? Bell-shaped curve. And the mean is equal to median is equal to mode. And that is equal to 0. There will be no difference between the mean, median, and mode. It will be all at the central, and both values would be like a bell-shaped curve. Skewed distribution is when you have skew is your tail. It depends on your tail. So if there is something like this is what you call the mean will be here, the mode will be here, and median will be here. The highest occurring is in the lower region, and mean is somewhere further away. So the tail is in the right side. So you call it right skew. Wherever the tail is, skew, 4 letters, tail. Right side, it's right skewed. Now, in case the values are like this, okay, in this, mean is greater than median, greater than mode. This is your right skew. Now, supposing the curve is like this, where mean is there, mode is there, and median is between. So, where is the tail? Left or right? Left side. So, this is left skew. Okay, that means the mode is the largest. Mode is greater than median, greater than mean. Okay, where can you see this? You can see it in Apgar. right? The highest occurring will be always like 9, 10, 9, 10, 9, 10. Some people will be having 8, 7, right? Are you getting my point?
Yes, sir.
അമ്മ ഇവിടെ വന്നേക്ക് വെക്ക. Okay, so if there is some values which are on the lower scale, like always occurring on the lower scale, something like 0, 1, 1. On the Likert scale, you're looking at the pain of in the surgery, not surgery. So, yeah, in the small surgeries cases. So most of them will say, I'm having only 1 pain, 1 pain, 2 pain, 2. Then one person might say I'm having almost 5. These are all small surgeries. So it will be right skew, right? All your values are in the lower value. 1, 1, 2, 2. Just some values will go into the tail side, that is in the 5. Are you getting understanding the distribution now? Normal distribution?
Yes, sir.
Okay. Now I want you to know one more thing. Measures of dispersion. Now I told measures of central tendency. Next is measures of dispersion. Dispersion means what? How is the data set dispersed? Is it very far off from each other, or is it located close to each other? That is basically a measure of distance. The easiest form is your range. What is your range? It is highest value minus lowest value. Okay. So that means highest value, if you have 90 and the lowest value was 10, range is 80. Okay. Then there is mean deviation. How much is each value deviated from the mean? Right? You have x bar, that is the mean, and each value. You have the first value, the second value. First, you have to find the mean of the whole data set. And then from each value, you are minusing the whole from the mean from each value, and then taking a summation of it and dividing it by the frequency, number of frequency, you will get the mean deviation. Okay. Again, you are getting an idea of the dispersion of each value, right? Next, you have something called the standard deviation. Standard deviation is nothing but root mean square deviation. So once what I do is I'm doing is the same thing. Mean deviation above x bar minus x1. I'm squaring it. Okay, divided by n. Sigma of the whole square of the whole. So since I'm squaring it, I have to do a square root of it. I have to do the opposite of it. Then only I'll get the correct value. This is what we call standard deviation. Now this inner part is called, there's another term for it, that is the variance. Okay. I got measures of dispersion. It can be asked what are the measures of dispersion? Range, standard deviation, mean deviation, and then you can put median in it. So median is not a measure of dispersion. Okay. Now there is something called coefficient of variation. Now coefficient of variation is a relative measure of dispersion. It wants to show you dispersion of the variables among different dispersion of the data within different variables. Okay, so if you want to look at systolic BP and height, okay, you took a group of 60 people and then you want to find which is more dispersed. This coefficient of variation, you get it from the formula standard deviation by mean into 100. So SBP, the standard deviation is, supposing standard deviation is 12 and the mean is 120 and the height is height of that population, mean is standard deviation is 8 and mean is 160. Can you tell me what is the coefficient of variation for each using this formula? Standard deviation by mean by into 100. Mm,
10.
10. And this 160, 8 by 160. 8, 70. Fine. So what does that mean? The values of systolic BP are more dispersed in this 60 people as compared to the height, which is not much dispersed among these 60 people. Okay, get my point? Are you understanding?
Yes, sir.
Okay, that is also a part of measures of dispersion. Next, I want to talk about is 95% CI. Okay. Now, for that, I need you to understand whenever we do a study, okay, you have a population, and I cannot do that if I am doing Chennai and I'm saying prevalence of falls among elderly in Chennai. I'm doing a study. Okay. And in Chennai, there are 1,20,300 elderly. Okay. Now the ideal method will be how will I find? I go to 1,20,300 elderly, interview them, and then I stop my research. I also stop my career, and I also die along with my results. Right? Okay. It's not like that. That's not what happens. What happens is when I can take one sample from this study population. This is something which nobody is teaching properly, and everyone gets confused why this is happening. I cannot take 1,20,300 and then finish my life. So I can take a sample of like around 100,000 people, and then I can extrapolate that result to 1,20,300 people. Now, when I talk about 95% CIS, if after I do the study among this 1,000 people, I got that the prevalence is 40% plus or minus 2 standard error will give you 95% CI. This is my point value, that is 40% prevalence, the proportion. Now, what does standard error mean? Okay. Standard error will give you an idea of, it is not an error actually, it will give you an idea of how your sample of 1,000 sample mean is deviated from the population mean. Okay. That means if at all there are 1,20,300, in 1,000 people, I said there are 40% prevalence of false. How much is it deviated from your actual population will be given by standard error. Okay. Now, standard error of proportion is given by the formula PQ by root n. You don't have to know that. When the proportion is that, P is your prevalence, that is 40%. Q is basically 100 minus P, that is 60%. And then you have to divide by a root of 1,000. Okay. You don't have to find the value. Just that I want to tell us the P plus 2. Now, when you have two standard errors, you get your 95% CI. Now, what that means is, if at all I do the study again and again and again from this 1,20,300 people, 95% chance is there the value of prevalence of false will be between 38 to 42, provided like standard error is 1. Okay, if you're taking standard error, supposing the standard error after calculating this, you got almost 1, you get 40 plus or minus 2 into 1. That is, okay, 38 to 42%. That means almost every time I do it, I have the chance that among 1,32,000, this is statistically that I'm saying that 1,32,000 times, among that population, the true value is between 38 to 42%. Are you understanding? I know it's a bit complicated. Hello? Guys? Hello? Hello? Yeah, I
Yes,
need
sir.
to, I need to continue, please. Sorry. Yeah, so that is what you talk about when you say sample mean and standard error. Okay, so in 95%, it means there are two standard errors. When there are, you're taking 68%, you're taking one standard error. Okay, that means 68% of times the population mean will be within that value. Okay, now we go to the next portion. Yeah. Next, we will go to statistical tests. What are the statistical tests that you can do? Okay. One you have to know is what is paired and unpaired. Okay. Then another thing is what is parametric and what is non-parametric. Now, paired and unpaired means you have one group of school students. Then you told them to exercise. Before exercise, you check the BP. The same group of students, you check the BP. Now you want to see there is any statistical significance between these two values. So is the group same? Then you call it paired. If the group is not the same, then you call it for instance, you have girls and boys, and you're checking BP. What is it? These two people are not the same type of group. So then they are unpaired. Okay. Now in parametric and non-parametric, parametric is all your uh, quantitative variables, and non-parametric is your qualitative variables. I've already explained qualitative and qualitative. I won't go into details of that. So when you compare a qualitative variable versus a quantitative variable. Okay, this is the statistical test that we use is depending on if it is dichotomous or polyautomous, you decide the test. If we are using two variables and the other one is more than two variables, then if it is unpaired, you use the something called the chi-square test. Then you have the paired test. That is called the McNemer test you do. If it is more than two variables, then you again use the chi-square test. Okay. Always remember, whenever you see qualitative variable, remember you have to use chi-square test. That must be the most probably they can ask in an MRBS. Okay. Now, if it is quantitative variable and comparing with another quantitative variable, quantitative variable is compared with versus quantitative. This also depends on the number of variables. If it is two variables, and if it's paired and unpaired, paired, if it is paired, then it becomes paired t-test. If it is unpaired, we call it the unpaired t-test. Now, when there is more than two variables involved, the statistical test is unpaired. We call it ANOVA. And if it is paired, we call it MANOVA. So these are the statistical tests. May or may not be asked, but good to know if you know. Okay, now I want you to know about what is alpha, beta error, what is null hypothesis. Okay, so what does it mean? What does null hypothesis mean? Anyone? Null hypothesis means whenever you're doing a study that is drug A and drug B, I am saying there is no difference. That is why we are saying null. Okay. So what is your alternate hypothesis to it? Your alternate hypothesis is there is a difference between drug A and drug B are not same. That is your alternate hypothesis. Okay. Now, when I do a study, there are two ways, right? I do a study and I say that there is already a drug B, okay, for MI. And then I do a study and I say, drug A is the best drug. Okay, now I did among some 10 people and I say drug A is the best drug. And then what will happen if I use drug A is better than drug B? What will happen? I will tell the manufacturer and replace it. Okay. So what it means that the alternate hypothesis is true is what is the alternate hypothesis? Drug A is better than drug B is false when in reality no, sorry, alternate hypothesis is true, you said, when in reality the null hypothesis is true. That is you have told alternate hypothesis is true, that drug A is a, but the actual truth is there is no difference between drug A and drug B. This is called as type 1 error or alpha error. Okay. So what you need to know is I again have to draw a 2 by 2 table. There are 4 situations that can happen. Okay. One is your reality. This is the ultimate truth. And the other one is your test, your study, which you did. And in reality, one is your null hypothesis is true. And when you did that drug A is same as drug B, you said null hypothesis is actually true. And in your test also, you said null hypothesis. So this is okay. This is correct. I don't care. Now, this is one aspect. There is alternate hypothesis is true. And null hypothesis, when you did the test, it is you're saying drug A is not equal to drug B. This is an error. Okay, this is one error. Now here also there is one error. You said alternate hypothesis is true when in reality your null hypothesis is true. This is your alpha error. Now when you the other part is alternate hypothesis that drug A is better than drug B, and in reality the drug A is better than drug B is also true. That means it's the power of the test. How can the test be able to actually know that there is a difference when in reality that is true? That's like that's good thing about one test, right? And the other aspect, this error is also the other error that I mentioned before is the beta error. So power is basically 1 minus beta, because this whole probability will actually be equal to 1. That is how you get power is equal to 1 minus beta. Okay, at least remember what is alpha error. Alpha error is when you say that drug B is not equal to drug B, but actually in reality, drug A is almost same as drug B. Now, which is more problematic? Alpha error is more problematic because why? Look at this. I did the study. I said drug B is better than drug B. Okay, and then what I'll stop drug B and then I'll put drug A into the market. Problem. Here, drug A, you said is equal to drug B. Okay, and because of that, you are not changing anything drastically. You're not putting a new drug or anything like that. Maybe the drug is good, but you didn't identify it. Because of that, you failed to earn. So always remember that alpha error can be always a bigger problem than beta error, and that is why you keep alpha error or p value. Any study, you'll always keep it less than 0.05. Any test you'll see will be below 5% because you don't want to give a wrong thing into the market. Okay, with that we'll end by statistics. Okay, now it will be a bit more fast. Yeah. Just want to go to biomedical waste management, some chapters which are very important in your. Okay. Biomedical waste management, very simple. I'm just going to the color coding. You have color coding system in biomedical waste management. What are they? You have the puncture-proof containers. You have a blue container, blue bag, red bag, and the yellow bag. Okay. There is a very simple way to remember this. Nothing doing. You don't have to remember anything. I'll show you a very simple method. First, start from white. Okay. You would have all seen puncture-proof container. Right? Puncture-proof container. It is white in color. Why is it puncture-proof? We are putting sharps into it. Finished? White is over. Blue is the next. Blue, what do we put? Metallic implants. And your medicines, you discarded medicines, you just put it into the blue. Okay. Once you open a medicine ampule, you have to throw it into the blue. So what goes into the red? In the red is your plastics, rubbers, and tubes. Okay. See, supposing somebody's on catheter, plastic. It's a tube. IV line, it's a tube. Rubber, gloves, tube, everything into the red. You think on these three things, you put in the red. Everything else will go to yellow. Okay, there are only four, and everything else is that human waste, animal waste, microbiological waste, everything will go into your yellow. Rest all will be in white, blue, and red. Okay, with that we finish biomedical waste management. Next we go into demography. Yeah, in demography there are four things, not stage. Yeah. Okay. In demography, I'm just talking about demographic transition. One is when populations start. Okay, initial period and all, if the health system is bad, they don't provide contraceptions, and what all those issues are there, what will happen is that population's birth rate and death rate will be high. Okay, will always be constantly on the upper side of the population. So you will not have any kind of development. So that is all in the initial stage. That is called as high stationary, where birth rate and the death rate is on the higher side. Later on, what you develop hospitals in the hospital, but you're not providing contraceptives, your death rate starts to fall. Birth rate is still in that same phase. That is called the early expanding phase. Okay. Now the birth rate starts to fall, also death rate starts to fall. And that is called as late expanding. When the birth rate falls and the death rate falls, it's called as late expand. Then both are low. When your condoms, everything you're providing, everything. So then the birth rate also comes down. Like in China, you had the one China rule. So, but then death rate is also very low. Nobody's dying. So then everything is low. That is called low station. Now there's a situation that is happening in Germany. People are living like there is a decline in the population. That birth rate is even going down. Further down, such that the population is declining. This is happening in only a Scandinavian countries. You don't look at the. If you want, you can remember through this how Prabhudev was dancing. First, he's showing birth rate and death rate, high station. Then birth rate is still there, death rate is coming down, early expanding, that is in countries like India and Africa. Then you, South Asia and Africa. India is in the late expanding, that is birth rate is also just coming down and the death rate coming down. See his hands, almost coming, both his hands are coming down. But yeah, when you come to countries like UK and Denmark, where Sritik is wearing coat, or both birth rate and death rate is low. Then you have declining. Declining means your death rate is even more down than your birth rate is going even more down. Look at his hands. Birth rate has even more down, gone more than the death rate. Okay, that is biomedical risk management. Yeah. Next, we'll go to yeah, vaccines. I need you to learn vaccines. One second. Vaccine. One second. One second. Yeah, next is yeah, National Immunization Schedule 2019. Important because it can come in your MRB. So at birth, what is it? At birth, you have three. So we used to have a cartoon, Bob the Builder. Okay. BCG, OPV, and Hep B. That is at birth. Then next comes at 6 weeks. 6 weeks, you have Penta, OPV1, Rota, and IPV1, fractional IPV and PCV. So you'll remember 6 weeks as pot P. Okay, then 10 weeks. Again, you're giving Penta 2. OPV2 and Rota2. So that is POR. I am not giving PI minus PI. Okay. Then at 14 weeks, I'm giving again POR P. Okay, I'm not going into the expansion of POR P. You know, I've already done same as 6 weeks. Then you have 9 to 12 months. When you have a child of 9 to 12 months, he will be wearing pajama, right? With that, you can remember pajama. These are the pajama vaccines. That is PC booster, Japanese encephalitis, and your MR vaccine. Okay. So 0 is over 6, 10, 14 weeks, 9 to 12 months. Next will be your 16 to 24 months. So the first thing that child sees on TV nowadays is Modi ji. What is Modi ji? M for MMR2 and G2. D for DPT booster and MOO for OPV booster, DPT booster and Modi ji, Japanese encephalitis. After that, 16 to 24 months, you have 5 to 6 years. You give DPT booster again. Then after that, 10 to 16 years, you can remove the pertussis DT booster. Always remember, even in pregnancy is also part of your national immunization schedule, and you give, now we are recommending TD. Okay, not tetanus. It's also with a diphtheria component. If it is primary, simple questions will be in your marking. You have to give 2 doses, one at the time of visit with at first visit, followed by 1 month apart. Then you have multi within 3 years, only 1 dose is required. If the pregnancy is within 3 years. Okay. Yeah. Next, I want to tell you how is the route of administration, because you will all be giving drugs in the route of administration of vaccine. Oral. This word itself will give you O for OPV, R for Rota, A for vitamin A. You'll never forget oral. Okay. O for OPV, R for Rota, A for vitamin A. Then you have your subcutaneous intradermal. Intradermal is your IPV and BCG. Simple IB. Okay. And always remember sub-Q. Sub-Q is MJ. Michael Jackson. MJ, what is it? MMR and Japanese encephalitis. Okay. So that is your subcutaneous. Then you have everything else, you can put it into IM. DPT, if anyone asks what is DPT, you know, have to say this IM. Next is site. So all the BJP, that is BCG, Japanese encephalitis, and Pentavac is on the left side. That is BJP on left. Usually doesn't happen. And all your IMR, MRI or whatever, MRI or IMR is on your right. That is MMR, IPV, yeah, MR, like MR, IPV, and your P for PCV. Okay, it's therefore on your right side. That's regarding your vaccination. So, yeah. So in certain situations, when you go to the rural areas and all, there are situations where you might have missed the vaccine, like BCG. You're supposed to give it 0. But sometimes, this is at a practical point of view, you go there and then the mother says, Ayo, Amma, the BCG எல்லாம் பண்ணது நமக்கு தெரியல என்ன பண்ணுவாங்க. If the child has not reached 1 year, you are supposed to give BCG. That is what is delayed immunization, and then you restart the schedule. Similarly, pentavalent can be given up to 1 year. IPV can be given up to 1 year. PCV can be given up to 1 year. Hepatitis B till 1 year. Rotavirus till 8 months. Beyond that, you can't give. There's no point in giving. And measles till 5 years. Vitamin A till 5 years. HIB till 6 years, and JE, Japanese encephalitis, is the longest. You can give almost till 15 years. Contraindications, pregnancy, all live vaccines. Whatever live you have, like measles and all, are live vaccines, except the yellow fever vaccine, you can give this contraindicated. HIV positive, all live vaccines again. Asymptomatic, no vaccines are contraindicated if they are HIV positive and they are asymptomatic. Symptomatic adult, all live vaccines contraindicated except MMR, varicella, and zoster. In fact, AIDS patients are almost prone for zoster, and hence we prefer giving them the vaccine. Newborn, all live vaccines contraindicated except OPV measles. Newborn, that is newborn to a AIDS patient. Then if you are immunocompromised, all live vaccines again, what is the problem? They have the chance of being virulent and causing the disease per se. Lactation, yellow fever vaccine is contraindicated. Fever, typhoid vaccine is contraindicated. Then diarrhea, if a patient comes to you, this is a very common situation you can follow in your clinical this thing. Child comes பேதியா இருக்கு 10 நாள் 2 நாளா பேதி இருக்கு தடுப்பூசி எல்லாம் போடணும் வேண்டாம் என்ன சொல்லும் நீங்க என்ன பண்ணலாம். There is no contraindication. You can give vaccines. This never should be a contraindication. In fact, the patient should get the vaccines. Epilepsy, DPT is contraindicated. During epidemic, all vaccines are contraindicated except measles. Vaccines require at least 6 to 8 weeks to form immunity. Hence, there is no point in giving certain vaccine during an epidemic of a disease. But measles, our incubation period is 10 to 14 days. That is almost 14 days it will take for the symptom to arise. But the incubation period of vaccine-induced measles is 7 days. அப்போ 7 days முன்னாடியே அவருக்கு antibody form பண்ணுவாங்க. So it is better to give measles vaccine during an epidemic. So what does it mean? You should use it at least within 3 days of that epidemic. Cold chain. The temperature of the cold chain should be maintained at +2 to +8 degrees Celsius. Okay. Now, what do you mean by cold chain? It is a maintenance of the appropriate temperature from the point of manufacture to the point of administration. You might have manufactured in Chennai. It has to reach some tribal village in Vellore. Again in Chennai, it has to travel all through truck, train, this thing, stores in somewhere, and then it will go through a vaccine carrier, and then you will get this thing, the drug or whatever, and that is distributed through vaccine carriers. This transport is known as the cold chain. The temperature is what is important, which is used as asked as an MCQ. The vaccine should be kept at +2 to +8 degrees Celsius. Remember all the temperatures +2 to +8 degrees Celsius. Wait. Okay. Just that at the state level, you have walk-in cold rooms or the walk-in freezer. You can store it up to 3 months of duration. In the community health centers or the district health centers, you can. I'm just removing the. Yeah, community health center or the district health center, you can you can store it up to 1 month, +2 to +8 degrees Celsius. PHCs, small ice-lined refrigerators. In PHCs, you will only have the small deep freezers. Again, you can store up to 1 month. At the sub-center level, when you are carrying in a vaccine carrier, you have to use it within 24 to 48 hours. This is important for you. Okay, you have to use within 2 days if you are wearing in a vaccine carrier. Now, whenever you look at the OPV, always remember the center can be darker than the surrounding. If the center is almost the same color as the surrounding, then it's fine. Then it's wrong. You should discard it. Okay. But if the center is darker than the surrounding, then it is again a problem. Only if it is lighter, you are allowed to use the OPV vaccine. Very important. Don't kill any patients. Don't kill any mothers. Don't kill anyone using your this thing. Okay. Next, I want you to go through something very, yeah, environment, nutrition. Yeah, adulterants. That's the important part. Okay. So what is food adulteration? Food adulteration is when you go to the shop and then you say ask for milk, they put water in it and you get substandard quality of food. It can be the addition of inferior quality of material or by extraction of valuable ingredient. What is a food toxicant? Food toxicant can harm you. Water and milk will not harm you. So what are the examples? In cereals, you use mud grits. Turmeric powder, you use lead chromate powder, that's yellow powder. Tea leaves, you use sawdust. Coffee powder, you use chicory. Those are all examples of food adulteration. Yeah. Mustard, antimony oil, if they use some antimony seeds, they are all similar to their. In ghee, you put vanaspati. These are all adulterants. Now, the examples of food toxicants are neurolatherism. These are MCQs. Neurolatherism is caused by a toxin, beta oxalyl aminoalanine, present in the pulse, Lathyrus sativus. Okay, it's also known as kesari dal. BOAA is caused this neurolatherism. Next is it's prevalent in the countries like Madhya Pradesh, Uttar Pradesh, Bihar, and Odisha. The disease affects the young men. If you see that person, the person will initially will be okay. Then he'll start using one stick. Then he'll need 2 sticks to walk. Then he'll be crawling on the floor. This is being in neurolatherism. Prevention is by banning the crop or using proportion of kesari dal. This will be in poor people. Okay, so this is primary prevention. I want to use this to understand. So the disease has not occurred. So before the disease occurs, you can ban the crop. That is specific protection. Then health education is your health promotion. Then if you are removing the toxin, then you can use steeping method or parboiling. Then there is genetic approach. Socioeconomic, Secondary prevention. Secondary prevention, disease has started. So it's as a treatment method, what you can do, you can give vitamin C. Administer vitamin C. You can give 500 to 1000 milligram of ascorbic acid. This could repair certain neurological damage. So the disease has started. That point is your secondary prevention. Tertiary prevention is all those people walking with sticks. You want to rehabilitate that person. So this is a very good example to know the levels of prevention, understand the levels of prevention. Aflatoxins is a group of mycotoxins produced by Aspergillus flavus. It is hepatotoxic. Moisture content is above 16% and temperature is 11 to 37 degrees Celsius, help in their production. It's been asked in NEET exams and all, what is the moisture content which contributes? Temperature is 11 to 37 degrees. No concept, only fact. You just have to remember. Prevention is keep the moisture content below 10%. This was the MCQ. At what moisture content should you keep to prevent aflatoxins to be formed? Should be 10%. Educate the local population. Ergot. Ergot is field fungus. It's caused by the Clavius purpurae. Ergotism symptoms will be acute like nausea, vomiting, giddiness from 24 to 48 hours of consumption. There will be painful cramp of limbs and this. Prevention is by floating them in 20% saline water, hand picking them. Epidemic dropsy, you need to know, will be asked as an MCQ. It is by contamination of mustard oil with argemone oil. Okay. What is the toxin involved? Sanguinarin. Okay. It accumulates pyruvic acid in your body and that will cause epidemic dropsy. Symptoms will be bilateral swelling of the legs and patient will develop dyspnea, cardiac failure. Seeds of the argemone closely resemble the mustard seeds, argemone oil, and argemone oil. Always remember epidemic dropsy. Test to detect argemone oil. This can be also asked on the instant. Nitric acid test or the paper chromatography test is the test for argemone oil. Okay. Then prevention is by axe and leave all that. Yeah. Endemic ascites. This is also a question. Endemic ascites is caused by paniculum miliare, known as godli. It is contaminated with the seeds of Crotalaria, known locally as junjunne, pyrrolizidine, alkaloids, hepatotoxin. It causes jaundice and ascites. Prevention is by educating, reading, and all this. Leave that. Go through environment also. Okay. Now in environment, air, you need to know what is air pollution. In assessment of air is air humidity. You can assess using the hygrometer. These are instruments. Air temperature and air movement gives the cooling power of this thing. Air velocity is measured by an instrument called the anemometer. Okay. 4 hours sweat rate. If for comfort level, within 4 hours, if only 1 to 3 liters of sweat, it is a comfort level. The maximum permissible level is beyond 4.5 liters, you will not have a comfort. Air pollution. What is the source of air pollution? I am not going to. This is important. Most important air pollution indicator is sulfur dioxide. This is the overall air pollution best indicator. But question will be soiling index is used in. You'll see soil and then you'll say that it's something to do with water or earth, ground, something. No, soiling index is known with air pollution, where a volume of air is passed through a white filter paper and the stain is measured by the photoelectric meter. Okay. Then, yeah, I'm not going to do other measures of air pollution is by grit and dust measurement, coefficient of haze, air pollution index. So always remember soiling index is for air pollution. Now measurement of light is something which is asked very recent NEET. So the SI unit of luminous intensity is candela. This is also by hearting. Luminous flux is lumen. Then illumination, when something is starting to glow, it is like lux. and luminance is your Lambert. So brightness of a point source, candle. You look at a candle, you know the luminous intensity. Okay. Then you have the flow of the light is like a tube through the lumen. And the amount of light reaching a surface is your lux. And the amount of light reflected from that is luminance and measured in Lambert. What is daylight factor? Daylight factor is your ratio of illumination at a given point to illumination at a point exposed simultaneously outside. So illumination indoors divided by illumination outdoors. Daylight factor should be in the living room at least 8%. This is also been asked. Kitchen, it should be at least 10%. Coming to loudness, a daily exposure of up to 85 decibel is above the limit a person can develop the disease. Hello? Yeah. 85 decibel is about the limit that people can tolerate without substantial damage to their hearing. The human ear auditory fatigue is more than 85. So just above 85, 90 decibels. But a deafness can happen if the 100 decibels is achieved. It will affect the organ of corti. Tympanic membrane is ruptured if it reaches 150 to 161. If you are near a blast or something and the sound does reach 150, it will rupture your tympanic membrane. Normal conversation is between 60 to 70 decibels. Okay. Yeah. What is the normal requirement of water? Every person has to drink at least 2 liters of water per head of day. Then I don't know. Yeah. I want to tell you about breakpoint chlorination. This is very important. Okay. So what you can do is when you go to a well, when you are going as a PHC officer, you want to disinfect the water. Water is not pure. So what will you put? You will put chlorine into water. Chlorine, when you put it, will form two components. One is the hypochlorous acid and another is hypochlorite ions. So this has the main role in the disinfection part. Hypochlorite ions have minor role in disinfection. It will not have any action. It will have an action, but the component that is important is hypochlorous acid. Now, what happens? In a well, you keep putting chlorine. Chlorine put, chlorine put, chlorine put. Now, initially there will be formation of chloramines. Then it will start destroyed. The chloramines will get destroyed. Then is your break point. What does it mean? There is a beyond the break point, you keep putting chlorine, you will get residual chlorine. Chlorine will not have anything to combine and chlorine will come out. This is your breakpoint chlorination. That is your free and combined residual chlorines will come out beyond your breakpoint. Now there are values for your breakpoint. At least residual chlorine should be in drinking water more than 0.5 milligram per liter for a contact period of 1 hour. This is also a question. How long should you keep chlorine to disinfect? You should at least keep it for 1 hour. If it is water bodies or post disaster, you should have 0.7. Swimming pool is the worst where everyone goes in peace. So you should put the maximum more than 1 milligram per hour and for a period of 1 hour. What is a Horrocks apparatus? Horrocks apparatus is to estimate how much of chlorine. You go to a well, how much you have to put chlorine is used by using the Horrocks apparatus. Then chloronome is for mixing or regulating the dose of chlorine. Chloroscope is for measuring residual levels of chlorine. Leave all that. Just remember this. Coliform organisms are used for understanding the contamination of your the best, most reliable this thing is for coliform organisms. You check E. coli and Klebsiella. Fecal streptococcus. If you see fecal streptococcus, somebody has shitted very recently. But if somebody has seen Clostridium perfringens, it means it's remote contamination. Yeah. So the presumptive coliform test is a test to identify how much coliform organisms is there. What happens is you take multiple tubes and then keep adding the reagent and see if there is any color change. Okay. The indicator is use of brown cresol purple. This thing in Macconkey's lactose bisulfur. 4 tubes is there. So each tube you keep on adding, and the first tube, depending on that, you will say there is coliform or yes or no. Now we go to. I don't want to go. We'll go into entomology. Okay. And the last part, last section, because this is one of the most important in this thing. What is in entomology? Entomology is the study of the arthropods of medical importance. This is your basic. You need to know this to tell what all diseases are there. Basic. Initial, you need to know these characteristics of each mosquitoes. There are anopheles, culex. Okay. Ticks belong to the class arachnid and won't be asked as an MCQ. But this you should at least have an idea. Mosquitoes cause malaria, filariae, viral encephalitis. Housefly cause all the other cholera, dysentery, diarrhea, typhoid. Sandfly causes a disease called Kala Azar, oriental sore. Sissy fly, sleeping sickness. They are loves can cause epidemic typhoid, relapsing fever, trans fever. Rat flea, plague. Okay, I told in the beginning of the class, no, the plague is a anthropozoonosis. It comes from the rat flea to the humans. So it's an anthropozoonosis. This is a stupid question that you keep asking. Yeah. Yeah, 1 second. Yeah. The eggs. This is what it's not a very keeps coming. They'll ask this question: which mosquito's egg is lays above or near the water surface? It will be above the water surface. You have to answer ADs. Everything others also on the water surface, and Mansoni is even underneath. It's attached to the undersurface of the leaves. Well, hello, hello, yeah. Just remember, Qlex is also the number will be in the form of RAFs or 100 or 4x. Both shaped eggs is seen in Anopheles. Okay. In adults, spotted wings are seen in very simple. These are the questions that can be asked in your MRB. Is seen in your Anopheles mosquito. Unspotted? No. Then mosquito-borne disease. Yeah, this is important. Qlex, Anopheles will cause malaria, filaria, while Qlex will cause Bancroft's filariasis, viral arthritis, Japanese encephalitis. Aedes will cause a disease called yellow fever, transferred dengue hemorrhagic fever, chikungunya. Okay. D diseases Aedes, dengue hemorrhagic fever, yellow fever, chikungunya. Mansorians cause another type of filariasis other than Bancroft filariasis, that's the Brugian filariasis. Okay. Okay. One more question that they ask is residual sprays is they'll say all of the following are anti-larval measures, and in that one of the options will be residual sprays. Residual spray is actually an anti-adult measure. It is not attacking the larva. What is residual sprays? You are spraying into the house and then leaving it alone. You're not going behind any lava and attacking it. Okay, you're basically giving that as your treatment measure. Remember, dirty water, Culex mosquito. Anopheles is like very, she live only in clean water. Okay, Aedes is seen in all your artificial collection of rainwater like rubber tires and all that. Mansonia is seen in aquatic plants. With that, I need to, this is all I can teach in such a period of time. Thank you for listening till this extent. Hello? Yeah. With that, I end my class. You can all. Thank you. Tamim, you can stop the class.
Okay, sir.
Okay, fine. Sure.
Thank you, sir. Thank you.
Okay.
Thank you, sir.